professors, eminent members, and one and all present here. This is Rajan Srivastava from AIMS Raipur with your kind permission starting my presentation. So I first have four pictures on the screen in front, and it's quite evident that what's common in all these four pictures. Yes, they all are visually impaired. But what's unique is that they show four different aspects of a common intervention, and that's rehabilitation. So that's my topic for presentation today, which is rehabilitation of visually impaired. Now, blindness is inability to see. So is it having only a physical dimension? No, I think not. It's quite evident that it's having all physical, mental, as well as social dimension. Now, WHO has defined blindness as a vision less than 3 by 60 and or a corresponding visual field of less than 10 degrees in the better eye with the best possible correction. Now, it is estimated that globally nearly 1 billion people are visually impaired. And in India, according to the National Rapid Survey on Blindness 2006 and 7, showed that the prevalence of blindness was 1%, which though dropped down to 0.36%, but still comparing with the demographic status, it's still quite high. Now, in the major causes of blindness, we have cataract, we have refractory errors, glaucoma, surgical complications, corneal opacity, and others, constituting 10%. Now, what's the cause behind such high rates? Now, about 30% of blind in India are said to lose their eyesight before 20 years of age. So we have major causes like malnutrition, which is not only related to vitamin A deficiency, but also to the other infections of childhood like diarrhea, measles, protein energy malnutrition being one of the major causes. Then we have occupational factors such as exposure to dust, particles, gases, fumes, radiations, etc. In the social class, poorer classes have twice more prevalence of blindness than well-to-do classes, and the reason being ignorance, poverty, low standards of person and community hygiene, as well as inadequate healthcare services. Now, Vision 2020, the right to sight, was enacted by WHO in 1999 with an objective to assist the member countries in developing a sustainable system to enable them to eliminate avoidable blindness from major causes by the year 2020. So when we're talking about prevention, it goes in the three headings of primary, secondary, and tertiary prevention. And it is the tertiary prevention in which we have rehabilitation. Now, it encompasses a wide range of clinical therapy as well as non-clinical training to provide blind as well as the low vision people with skills and tools to maintain a safe, independent, and active lifestyle so that they can participate in education, they can travel safely, meet their career goals, and enjoy the activities in their life. So it could be educational, vocational, social rehabilitation, or daily activities and mobility. Now, coming first with educational rehabilitation, WHO estimated that nearly 6 million blind or low vision preschool and school going age children, about 80% live in those developing countries where only 1 out of 10 has access to basic education, which is basically due to lack of properly trained teachers, lack of awareness, and limited federal policies. So the various modes of intervention, first we have making dedicated schools for blind and making trained teachers so that they can teach them well. Then we have a special calligraphic system in the form of a braille alphabet, which enables them to learn the letters. Then we have some modern braille system in the form of electronic braille, electronic keyboard system. And then we have another, such as the sound system, which uses a webcam that converts the visual signals into auditory signals perceived by the auditory cortex and then synchronizing with the visual cortex and making the person hear what is front. Now, after the person is educated, the next question he asks that what is his career with visual impairment? Now, what a blind person can do for a career. So here comes the role of vocational rehabilitation. So there are various kinds of jobs which a blind person can do, such as a guidance counselor, college professors, psychologists, physical therapists, rehabilitation teachers and counselors, and customer service representatives. Now, the government of India has implemented this Persons with Disability Act 1995, which mandates at least 1% of job for visually impaired people in government and private sectors, and it has actually paved the way for the visually challenges to work. So we have examples in the form of the self-employed ones, like in this picture, making masks and working in the community services, means making the work ergonomic for them. Now, after vocational rehabilitation, now we all know that every person wants to be independent on its own. That they can do their own work, they can do their daily activities, and they can mobilize themselves. So for that, we have this Third Eye for Blind project, which is a recent innovation which enables them, which basically solves the problem with the help of these wearable bands that produces ultrasonic waves, which notifies them of the surrounding with burst sounds and vibration. We have examples in the form of these bands which sense these ultrasonic vibrations and make them unable to see what surrounding object. So it uses these mini cameras, the embedded sensor of motions, the ultrasonic sensors, and make them aware of the surrounding. Okay, the modular ones, we have these wearable goggles, the wristbands, the sticks. Now, after that, we have mental and social rehabilitation. Now, in many instances, the situation of visually impaired people is basically as a result of misconception about their capabilities. And it is mainly the developing countries where training and technological resources are so severely limited that visually impaired individuals are often excluded from their workplace, society, or they become disheartened. So basically, in this rehabilitation process, we want to make the general public aware that what are the conditions these persons are going through. And we make the people understand that blind are not able to see anything, but they do their work very much greatly. And this, I would like to put certain examples like Helen Keller. Okay, we all know. Then is Mr. Louis Braille, the founder of the Braille system. Then another famous example of Mr. Ravindra Jain, a great music composer and a singer, and just impossible to list all the great albums and hits he has given. And then quoting out of many, my last example of this great personality, Mr. Ankur Dhama, the Indian Paralympic who won several medals in national and international championship for running and who participated in the Rio Paralympic event. So I would like to just say here that though they have lost one senses, but they have strengthened their other senses, which makes them to stand extraordinary out of the normal people. And then finally, I would like to conclude my presentation by quoting that respect blind people because they don't judge others by their look, but by their head. Thank you very much.
Professor Mojumdar, Madam, please, do you have any question? Hello. Hello.
Hello.
Professor Mojumdar, do you have any question? Rajan?
Yes,
can you
ma'am.
hear me? As
Yes,
an
ma'am.
ophthalmologist, how can you share your help, or how can you offer your help to the blind people?
Ma'am, as an ophthalmologist, the major cause of blindness is because these persons are either not able to get to the proper health facilities in the earlier stages, or they are diagnosed at a very late stage where the changes becomes irreversible. So we can set up community health camps in rural areas so that we can gather people who are visually impaired. We can do their checkup so that they can diagnose at an early stage where the changes are not have become irreversible so that it can be reversed.
That is
And
very good one. Yes. That's a very honest and sincere effort that will be in take, I think, and it should be started at a very basic level. No. Okay.
yes,
Thank
ma'am.
you,
At the rural
Professor.
level.
Yes. Professor Mojumdar, do you have any question? Hello. Hello. Shuchitra ma'am. Shuchitra ma'am. Okay, I think we should move on to the second speaker, Komal.
Yes, ma'am.
Komal, you may start
Yes.
now.
Ma'am, is the screen visible?
Yes. Yes, it is visible.
Yeah, may I
You
start?
can start. Yes.
Yeah. Good evening, respected professors and all the participants. So I am Komal Garg from Government Medical College, Raigarh, Chhattisgarh, sharing my presentation on the topic treatment of myopia. So before we start treatment of myopia, let us see what is myopia. So myopia, it is also known as short sight, and it is a dioptric condition of eye in which parallel incident rays focus anterior to the light sensitive layer of retina when accommodation being at rest. So basically what we need to do in treatment of myopia is either we treat the cause of myopia, or we can do or what we can do is we can diverge the light rays so that they focus on the retina. So for treatment of myopia, we can either give the patient spectacles, contact lenses, or we can do surgeries. So in case of spectacles, as we saw earlier, that there is converging of light rays in anterior to the retina. So what we can do is we can give diverging lenses or concave lenses, or we can say negative powered lenses to the patients so that the light rays gets diverged and they converge at the retina. Other than this, what we can do is we can use contact lenses in patients in high myopes. Then the surgical modalities of myopia can be radial keratomy, photorefractive keratectomy, laser assisted in situ keratomiliosis. Out of these, photorefractive keratectomy and laser assisted in situ keratomiliosis, these both are laser surgeries. Then small incision lenticule extraction, refractory lenticule extraction, Fukalas operation, photorefractive lenses, which use implantable columnar lenses. So first of all, let us see radial keratomy. So what we do in this surgery, we make radial incisions on cornea so that when these incisions heal by fibrosis, there is contracture which flattens the curvature of cornea. So as we know that myopia, that cause of myopia is also curvatural myopia, in which the curvature of lens gets increased, which cause converging of light rays in front of retina. So by this operation, what we can do is we can decrease the curvature of lens, curvature of cornea, so that the power of eye gets reduced, and then the myopia can be treated. But this surgery is not done nowadays because in this case cornea gets weakened and there are chances of globe rupture, and it is also and the patient also feels glare at night, and uneven healing of cornea may also lead to irregular astigmatism. Then in case of laser surgeries, now in my own batch there are so many students facing who are suffering from myopia. So it is a very common problem, and all my non-medicos friends, they also ask me that should we get laser done. So what are these laser surgeries? So laser surgeries include two main surgeries, that is photorefractive keratectomy and laser assisted in situ keratomiliosis. Now both these surgeries, these use excimer laser, which is an argon fluoride laser which gives wavelength 193 millimeters, and the mechanism is that we photo ablate the cornea, which leads to flattening of cornea. So here, by the help of a microkeratome, we create a nasally hinged epithelial flap, and then we ablate the corneal stroma. Now we first of all we get the refractory test done so that we know how much diopter myopia is the patient suffering from. So for every 1 diopter myopia treatment, we have to ablate 10 microns of the cornea, and we have to leave the residual stromal thickness for more than 250 micrometers. Now what post-operative advice should we give to the patient? As we have created a nasally hinged epithelial flap, so we advise patient not to rub the eyes, because due to which epithelial flap may get disrupted, and when it heals with opacity, which may hamper the vision of the patient. Then other than these, the latest surgeries include, first of all, small incision lenticule extraction surgeries or refractive lenticule extraction. In these surgeries, what we do, we again remove a part of cornea which decreases the thickness of cornea and again decrease the curvature of cornea. And here the laser used is ND glass laser. Then Fukalas operation. In this operation, what we do is we in patients with very high myopia, like we know that the refractory power of the lens is around plus 16 to plus 19 diopter. So if the patient is having very high myopia, so we extract that clear lens from that patient and we implant the lens of a proper power, of appropriate power, and hence the myopia of that patient can be treated. Then in case of phakic refractive lenses, this is done in very high myopia in young patients. So we implant an implantable Colimber lens over the normal crystalline lens of appropriate power to treat the myopia of that patient. Thank you, ma'am.
So Komal,
Yes, ma'am.
what is RK? What is the full form of RK?
Ma'am, refractive keratomiliosis.
Now, is it keratomy as you have spoken? Radial keratomy. What is the actual term? Radial keratotomy.
Yes, ma'am. Sorry, ma'am.
But the you have mentioned radial keratomy, so the terminology is wrong, right?
Yes.
Please be careful.
Yes, ma'am.
Okay, now what new message you want to convey to your presentation?
I want to convey that myopia, it can be easily treated, and we should know the different modalities available as to suit the patient as per the needs of the patient. For example, if we do radial keratotomy in patients who are at a high risk of blunt trauma, like sports person, athletes, or military personnel, so we have to change the modality of our treatment in those cases. So basically, there are so many modalities for treatment of myopia. So we provide various variety of treatments for the treatment of myopia according to the needs of people.
Right, and there is some special situation like keratoconus.
Yes, ma'am.
So did you come to your mind? Can
Yes, ma'am. As keratoconus, in keratoconus, what happens? There is increased curvature of myopia. So it is also a cause that it may lead to there is increased curvature of cornea. So it can also cause myopia. So and it can also be treated. So yes, keratoconus patients can also be treated with various treatment modalities.
Okay, thank you.
Thank you, ma'am.
So Professor Majumdar, Shulita ma'am. Hello, Professor Majumdar. Madam, are you there?
Ma'am, shall we continue?
Hello, Professor Majumdar. Hello, Professor Majumdar. Are you there? Ma'am, you are visible. Hello, I need some technical support. Is there anybody from Impaired? Mr. Ashwin? Hello.
Yes, ma'am. Tell me, how can I help?
Professor Shuchitra, her I think audio is making some problem. Can you please check on this? Hello.
Yes, doctor.
Is it resolved? No.
Yep. Doctor, बात बताइए.
Professor Mojumdar.
Professor Mujumdar is another one.
Okay, so Damini, you can start now. Hello.
Yes, ma'am.
So Damini, you can start now.
Yes, ma'am. Is my screen visible?
Yes. Yes, it is.
Okay, just a second. So, good evening, everyone. Myself, Sudhamni Tandi from Government Medical College, Jagdalpur. My topic name is xerophthalmia. So, what is xerophthalmia? Xeros means dry and ophthalmic means eye. Okay, so these are the ocular manifestation of vitamin A deficiency. Okay, so what is vitamin A? Vitamin A is a fat soluble vitamin. So if we talk about any micronutrient deficiency, it is due to mainly two reasons. Either there is a deficiency or there is a defective absorption. Okay, now under those headings, there are many causes like protein energy malnutrition, chronic alcoholism, selective dieting, okay, diarrhea, measles, and mother malnourished condition. So other forms, active forms of vitamin A are retinol, retinal, and retinoic acid. Now, functions of these active forms are retinol is for reproduction, retinal is for vision, and retinoic acid is for growth, development, and epithelial gene differentiation. So here we are presenting the epidemiology of xerophthalmia. So you can see these darker areas like Madhya Pradesh, Jharkhand, Haryana, they are the highly prevalent areas for xerophthalmia in India. However, xerophthalmia is you can say more prevalent in Japan like countries. In India, it has a proportion but very less. Now, this is the main proportion. This classification was given in 1982. It states the stages of xerophthalmia. Okay, so what are the stages of xerophthalmia? That is XN, night blindness, X1A, conjunctival xerosis, X1B, Betot spot, X2, corneal xerosis, X3A, X3A, and X3B. See, here X3A it covers less than 1/3 of corneal surface, and X3B covers more than 1/3 of corneal surface. Okay, and this is XX, that is corneal scar, XF, that is xerophthalmic fundus. Now, we will look upon these stages brief here in detail. Now, what is night blindness? Night blindness is the earliest symptom of xerophthalmia in children. Okay, night blindness, that is nectalopia. There are other conditions also where night blindness elicit like myopia, glaucoma. Okay, but here we will exclude xerophthalmia by taking proper history. Now, as every disease progresses from outer to inner, outermost layer, that is conjunctiva, it will hamper conjunctiva earlier. It will make conjunctiva dry, lusterless, non-wettable, conjunctiva emerging sand. This is a pathognomic feature, that is sandbags at receding type. Okay, it will exhibit in the temporal surface of conjunctiva. Bitot spot.
Excuse me, excuse me. Sorry for the interruption. Shudhamini?
Yes,
you are only on the slide number 1. Are you displaying slide 2, 3? We are not getting it.
Ma'am, there will be shown internet connection problem.
Okay.
Just a second, ma'am. Just a second, ma'am.
Yes. Take your
Ma'am,
time.
is it visible now?
Well, it's visible, but it has become static, only a slide, the first slide is visible,
Okay.
not the subsequent slides.
Ma'am, shall I restart it? Ma'am, let me try.
No, I think you just slideshow. What did you do? Slideshow?
Yes, ma'am. I had just.
Yes, now it's visible.
Now it's
Yes.
visible, right? Okay. Okay. So,
Yes.
okay, ma'am, please give me extra time for that. Okay. So I was talking about xerophthalmia. I had explained about the dry eye, its etiological factor, that is it due to deficiency or due to malabsorption. Okay, like alcoholism, malnourishment, diarrhea, measles, its active forms and their function. And then we see the epidemiology of xerophthalmia, where these darker areas. Ma'am, is it visible now?
Yes.
Hello, ma'am. Yeah, ma'am.
Yes, it is visible.
Thank you, ma'am. Okay, so these darker areas, Jharkhand, Madhya Pradesh, Telangana, Andhra Pradesh, these are the prevalent areas for xerophthalmia in India. However, xerophthalmia is not a public health problem in India. It is in Japan. But as we say, prevention is better than cure. And this is the classification table of xerophthalmia. It was given in 1982. Okay, and here are the stages of xerophthalmia. That is XN, night blindness, X1A, conjunctival xerosis, X1B, white dot spot, X2, corneal xerosis, X3A and X3B. Okay, X3A covers less than 1/3 surface of corneal, and X3B it covers more than 1/3 surface of cornea. XX is the corneal scar stage, and XF it invades fundus, xerophthalmic fundus. Okay, now we will look upon these stages in detail. Night blindness, that is XN. It is the earliest symptom of xerophthalmia, that is nyctalopia. There are other conditions also where nyctalopia elicit, like myopia or glaucoma, but we will exclude this xerophthalmia by taking proper history. Now, conjunctival xerosis. Okay, conjunctiva is the outermost layer of our eye, and conjunctival xerosis will present as sandbags at receding tide in temporal area. Now, bitoid spot. Bitoid spots and bitoid spot are the pathognomic feature of xerophthalmia. These are the foamy triangular patch of keratinized epithelium on bulbar conjunctiva in the interpalpebral area. These are bilateral, temporal, and they are less frequently visible on nasal area. And if they are seen, then it is confirmed that this patient will have xerophthalmia. Now, corneal xerosis. After conjunctival, it will start invading cornea. This is the earliest change in cornea, that is punctate keratopathy. Disc-shaped changes will be seen in cornea, which will begin in lower nasal quadrant, and then it will cover the whole cornea. Then corneal ulceration. It is a stage where whole cornea will be covered. Those disc-shaped punctate keratopathy, which I had mentioned here in this slide, they will coalesce with each other and form a collicutive necrosis, that is liquefactive necrosis, and cover the whole cornea, forming stromal defects, which will further result in blindness, because as we know, if cornea is invaded, then pupil area and visual access will be hampered. Now, as we all know, cornea is avascular, right? It has neither blood supply. Okay, this has no proper blood supply, so it will heal by forming scar. The scar will not you can say disappear. It will form a scar after healing, and by healing it will affect the pupillary area. If it will affect the pupillary area, the visual area will be affected, and if it not, then visual area will be preserved. Now it will hamper the fundus area. In fundus, seed like raised whitish lesions scattered uniformly over the fundus part at the optic disc level. Okay, so it will hamper the optic disc. So as we had seen earlier, it had started from conjunctiva and then it progressed to fundus. So if we will prevent it at the conjunctival stage only, that is at the earlier stage only, we can prevent a blind. Okay, so how can we prevent it? First of all, we will diagnose it. From how? Okay, so we will diagnose it by its symptom, that is night blindness and ocular irritation due to dryness, because there is xerosis everywhere, so there will be dryness. We can investigate by and by investigation we will confirm it by cytology, squamous metaplasia, xerosis, and serum. In serum we will see decreased retinol binding protein. Okay, so These are the therapy that we can give. For conjunctival cirrhosis, we will give artificial tears, keratomalacia treatment as per the cornea also. Vitamin A therapy. Vitamin A therapy plays a very important role for the prevention of xerophthalmia as per the age criteria. Above 1 year of age, we will give 2 lakh international unit orally, and if not orally, then 1 lakh international unit intramuscular every 4 weeks later. If there is woman of reproductive age, pregnant or not pregnant, in certain stages, we will give 10,000 international unit. And treatment of underlying conditions such as protein energy malnutrition, nutritional disorders, and diarrhea, as we had seen in etiology itself, that these are the initial causes of xerophthalmia. So first we will treat the causes, then only we can treat the xerophthalmia, right? And then after treatment, we will see prophylaxis. In prophylaxis, we have 4 stages. That is short-term approach, medium-term approach, long-term approach, and preventive measure. What is short-term approach? Short-term approach, it covers infants, children, and lactating mother, those who are more prone to it, right? So in infants, we will give 6 to 12 months infants and who are less than 8 kg, 1 lakh international unit orally, and children who are over 1 year, 2 lakh international unit, and lactating mother, 20,000 international units. Sorry, it's 20,000, and above the variable is 2 lakh international unit. Once at delivery, in lactating mother, it is given once at delivery and during the next 2 months. And in this, we have seen a short-term approach. And in medium-term approach, we will fortify vitamin A with huge fortification so that with regular intake, people will take vitamin A and it will prevent the deficiency. Long-term approach promotes the promotion and adequate intake of vitamin A rich foods like spinach, carrot, right? And in preventive measure, we will use dark goggles. So the dark goggles will prevent the xerost part or the less exposed to eye. Now, this is a program, national program that has been initiated by government, that is Child Survival and Safe Motherhood Program. These are the standard values and standard age that is included in our immunization program also, which will prevent xerophthalmia. That is first dose 1 lakh international unit at 9 months of age along with measles vaccine. Now, vitamin A and measles have a special bond with each other because when vitamin A is administered, it forms special antibodies. It will form antibodies against the measles. Okay, so that's why measles and vitamin A are administered together at immunization schedule also. Now the second dose is with 2 lakh international unit at 18 months along with a booster dose of DPT and OPV, and the third dose, that is 2 lakh international unit, it is administered at 2 years of age. Thank you.
Okay, no question. Next speaker, please, Kanika.
Yes, ma'am. Ma'am, can I
You may
start?
start now. Yes.
Okay, ma'am. Ma'am, is it visible?
Yes, it is.
Good afternoon. Today, I'm Kanika Agarwal from Santosh Medical College, Ghaziabad, is going to present on eye banking. It is an organization which deals with the collection, storage, and distribution of cornea for the purpose of corneal grafting, research, and supply of the eye tissues for ophthalmic purposes. There is a 3-tier organization which is composed of eye donation centers, eye bank, and eye banking training centers. It is an integrated system involving a 3-tier community eye banking pyramid based on the infrastructure and manpower at all the levels. There are different functions of the eye banking. First, it is used for research activities. Second, it is used for distribution of the donor tissues to the corneal surgeon, promotion of eye donation, preservation of the tissue for short, intermediate, long, and very long term, registration of the pledge for the eye donation, receiving and processing the donor's eye, and collection of the donated eyes. There are various myths about the eye donation due to which people don't donate their eyes. These are face and body will be disfigured, will be born blind in the next birth, will not be able to see the God. Various facts about the eye donation are: eyes should be donated within 6 to 8 hours of the death. Only the cornea is used for the transplant. Total removal time is about 15 to 20 minutes. Eyes are not bought or sold. All religions endorse eye donation. Who can donate the eyes? Anybody can be an eye donor irrespective of their age, gender, blood group, and religion. Spectacle wearers, hypertensive, and diabetes can also donate their eyes. Corneal blindness. 2 million people out of 25% of total blind in India, 1.5 million are unilaterally blind and 0.5 million are bilaterally blind. There are around 40,000 to 50,000 new patients every year, and there is a need of 1 lakh keratoplasty per year and 2,000 corneas per year if we can enhance our utilization up to 50%. Equipments. Mandatory equipments for the eye banking are refrigerator with temperature recording device, biological safety cabinet or operation theater, slit lamp, sterilization facilities, enucleation and corneal excision instruments. And desirable equipments are incubator, specular microscope, ultrasonic cleaner, ice machine, microbiology facilities, and centrifuge. There are 6 steps of eye donation. They are: donor selection. We need to select the donor, that is who is appropriate to donate the eyes. Tissue retrieval. Then third is corneal examination. Fourth is tissue transportation. Fifth is storage of corneal tissue. And sixth is distribution. Donor selection. Age of the donor. No influence of the age on transplant outcome. Older age, usage rate declines, and the lower limit is 2 years to prevent myopic shift after keratoplasty. Eye banks must have consistent policies for the examination and documentation of the donors available. They need to check the medical records, medical history, cause of the death, medications, and laboratory reports of the donating person. Eye bank preservation media are short term, intermediate term, and long term. Short term is done for 48 hours using moist chamber. Intermediate term 4 days for McCarry Kaufman medium, 4 days for K-Sol medium, and 7 days for Dexol medium, and 10 days for Optisol medium. Long-term storage is for organ culture, 35 days, and cryopreservation is for 1 year. There are various contraindications for the eye donation: the systemic conditions and the ocular conditions. The systemic conditions are HIV, rabies, and viral hepatitis, and ocular conditions are retinoblastoma, active inflammatory diseases like conjunctivitis, iritis, uveitis, and retinitis, and congenital abnormalities like keratoconus, keratoglobus, and central opacities like nebular, macular, and leukomatous opacities, and pterygium. What are the things after donation? First, the donor's family receive a certificate of appreciation from the eye bank. Step 2, eyes are evaluated at the eye bank and only the ones deemed suitable are used for transplant. Others are used for research and education. Step 3 is corneal transplantation should be done within 2 to 3 days post removal. And step 4 is recipients are notified on a first come first serve basis from the registry. Legal aspects in India. Under the Transplantation of Human Organ Act 1994, the qualification to perform enucleation has been reduced from MS ophthalmos to MBBS. Eye donation is always decided by the donor's surviving relatives and not by the actual donor. Enucleating doctors always have to legally obtain a written consent from the relatives of the deceased before they actually remove the eyes. Thank you. Hello. 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 Hello.
Yeah, Dr. Kanika, we are waiting for somebody to respond.
Okay, ma. Okay, sir. Sorry. I thought it is not audible.
Dr. Sati, Dr. Suchitra. Dr. Sati. Dr. Swati. Dr. Suchitra.
Hello.
Ma'am, are we done with the presentations?
Hello.
Yes, ma'am. Can I hear me? Hello. Dr. Suchitra, Dr. Swati.
I'm here. Dr. Swati is here, but Dr. Shuchitra's, I think audio is not working.
Okay, Dr. Swati, are we done with the presentations? Do you want me to close
Yes.
the session?
Yes, Kanika has finished, no?
Yes, ma'am.
Yes. Ma'am.
Kanika, can you just read out the last slide?
Okay, ma'am. 1 minute. Ma'am, this one, legal aspects in India.
Okay, Kanika,
Yes, ma'am.
how do you think, how can you increase eye donation, the
Ma'am,
number of eye donations?
ma'am, till today, people are not aware about the eye donation. So we can make them aware about through the posters, through the slogans, by doing the street plays. We need to make them more educate that there is no harm in eye donation, and we can also tell them that they may help two other two people to light up. Because one person can donate eyes to two-person, and even if they have any of the chronic diseases like diabetes, hypertension, they can even donate their eyes.
Okay. Okay, thank you.
Thank you, ma'am.
Okay, Mihir, Dr. Mihir
Yes.
Kulkarni. Yes, you can start now.
Yes. Okay, ma'am. Hello. Hello.
Yes, you are visible. Your screen is visible.
I am visible. Just give me 1 minute. My internet is a little slow, ma'am. I'm very sorry. Okay, ma'am. Can you see my screen now?
Yes.
Hello. Okay. So good evening, everyone. My name is.
Dr. Mayor, you can put it in PowerPoint mode. Screen or just put it on sharing mode. Hello, Dr. Mayor.
Hello, can you hear me?
Can you put it in PowerPoint mode?
Hello.
Yeah. Dr. Mayor.
Yes, sir. Yes, sir. Can you hear me? Can you?
Can you just share it in PowerPoint show mode?
Audible to आधा तो होता है.
What can you put it in PowerPoint show mode?
Hello.
Hello. Yeah. Can you hear me?
Yeah, I can hear you, sir. I can hear you, sir.
Can you put it in PowerPoint show mode?
Sorry, sir.
Can you put it in PowerPoint show?
1 second, sir.
That on the right hand side bottom,
Can you
you
repeat?
see there is a TV on icon.
Slide share. Go to slide share.
Right bottom.
Hello.
Next to minus sign, there is an icon. Bottom में.
1 second, sir.
Just click on that.
Sir, can you see the slides right now?
Can you do me,
Hello?
Dr. Meher? Dr. Meher? Dr. Meher? Dr. Meher? Dr. Meher, can you hear me? Dr. Meher?
Hello? Hello?
Dr. Meher? Dr. Meher?
Hello? Hello?
Ma'am, he's not able to hear us. I can't hear him.
Hello.
Yeah, can you stop and reshare on the top? There is something called slideshow. Dr. Megan, on the top there's a slideshow on the menu bar. On the menu bar, next to animations, there is slideshow. Dr. Meher, in the top menu bar, there is something called slideshow. Just click on it and start from the beginning. Slideshow in the top menu bar. Taskbar, optical देखिए. Slideshow लिखा होगा left hand side पे जाइए.
Judges are requested to stay.
Hello. Can everyone hear me right now?
Stay in hall. আমি লিখে দিলাম হ্যাঁ
Hello. Can everyone hear me right now?
So just announce the name of the best and second best of this hall and ask them to stay over here. Best and second best, two. Hello.
Hello.
Professor Samantha speaking.
Yes, sir.
Professor Samantha speaking.
Sir, this is me.
Please ask the judges to declare the name of the best one and the second best one of these batches of students and ask them to stay over here. We will start the best of the best session here. Okay.
Disqualified.
আমাকে এখানে হল 1 টা কি হল হল 1 नीचे तक
This will be used.
करके थोड़ा हॉल 1
Hello.
Dr. Saman, there are 2, 3.
Yes.
Dr. Saman.
So from this hall, who have been selected?
Dr. Saman, there are few people who are not.
I cannot hear.
Dr. Saman.
Yes. एक पंखा बंद करो, कुछ नहीं सुनाई।
Sir, few doctors have not presented, sir.
Hello.
Sir, अभी 2-3 बाकी है, sir, 2-3 ने present नहीं किया।
अभी भी presentation बाकी है?
हाँ।
ठीक है, चालू रखो। जब ये presentation खत्म हो जाए, उसी के 10 मिनट के बाद next session शुरू होगा। Best of the best, ठीक है?
Dr. Om, can you start sharing your screen? Dr. Om, sorry.
Yes, sir. Yes, sir. Hello.
Who's not
Yes,
presenting? Please screen after knowledge.
Hello.
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 खत्म हो जाएगा
Hello.
Hello, चालू रखो। Hello, Dr. Samantha speaking.
Hello. Can you? Yes, sir. This is Mihir Kulkarni.
Yes.
Hello.
Hello.
Sir, can
Are
you
you
hear
present?
me?
Yes,
Sir, can you please
I can hear. All right. Please
Okay,
carry
sir.
on the
Can you
session.
see the screen right now?
Yes.
Okay, sir. I'll be starting my presentation.
please do.
Okay, so I will good evening, ladies and gentlemen. My name is Mihir.
Here we can't see your screen.
Hello.
But Mihir,
You can't see the screen?
your screen is
Yes,
not
ma'am.
visible. Your screen is not visible.
My screen is not visible.
No.
1 second, ma'am. I'm just looking into it. Ma'am, can you see it now?
Yes, now it is visible. But go to slide.
It's visible
show.
now?
Yes, it is visible. The first slide.
Ma'am, can I present it like this? If it's visible right now, then it's better not to change it. No, ma'am?
No, but you have to show us the subsequent slides. Go to slide show,
Ma'am,
I think.
I can present it like this, ma'am. I don't
Yeah,
think
just click on from the beginning, from the top icon. Like just on the top, there is icon called slide.
Okay, ma'am. Can you see it now? Can you
Yes,
see the
yes.
slide now?
Yes.
Hello? Okay, you can see it now. Okay. Okay, I'll be starting my slide now. Okay. So good evening. I'm sorry for the delay because my internet connection is poor. So I'll be presenting my topic, vernal conjunctivitis, spring scare for the eyes. Hello?
Yes, continue.
I'll be continuing. Okay. So as we know, vernal keratoconjunctivitis is a form of allergic conjunctivitis, also known as non-infectious conjunctivitis. It is typically recurrent in the springtime, hence the name. It is bilateral in presentation, and it is a type 1 hypersensitivity reaction mediated by the IgE and cell-mediated immune mechanisms. If there is a corneal involvement that is seen, it is usually associated with ocular morbidity such as keratoconus, superficial keratopathy, and permanent visual loss in untreated cases. So epidemiology and demographics. The age group is from 5 to 25 years. Majority is present in the adolescent age. Hello?
Yes, please
Hello?
continue.
Can everyone hear me?
Yes, you are audible.
Okay, sorry.
You just
So
continue.
as we know, okay, ma'am. Okay, ma'am. So epidemiology and demographics. So the most prevalent age group is from 5 to 25 years, mostly seen in the adolescent age. It is more commonly seen in males, and it's usually associated in warmer climate zones like India, Mediterranean, Sub-Saharan Africa, and Middle Eastern countries. The occurrence, it usually occurs with peak incidence over late spring and summer seasons. So pathogenesis, it's like I said, it's a type 1 hypersensitivity reaction. So it's caused due to exposure to exogenous as well as endogenous allergens. Exogenous allergens include pollen from flowers like primula as well as exposure to animals. Endogenous allergens include bacterial proteins such as staphylococcal infections, and which is usually present in the nasal cavity and upper respiratory tract. It can be associated with hay fever as well. And it can also be drug induced, such as atropine and brimonidine. These drugs can induce a VKC case. So pathophysiology, a personal or family history of atopy is usually seen in a large proportion of VKC patients. And like I said before, it's a type 1 hypersensitivity reaction. So activated eosinophils as well as mononuclear cells can be observed on scrapings. Along with this, in some cases, there are type 4 hypersensitivity reactions as well with immunomodulator involvement like interleukin 4, 5, and BFGF. So clinical features, classification, and stages. So it's broadly classified as palpebral, limbal, and mixed variety of VKC. The symptoms that is seen in any of these cases, the most prominent symptom is intense itching. Along with this, you have redness and watery secretions. Now, with the watery secretion, you have a characteristic sign which is known as a Maxwell-Lyon sign, which is a characteristic whitish ropey discharge, which is characteristic of VKC. Other associated symptoms include lacrimation, photophobia, foreign body sensation, burning, blinking, blepharospasm, dry eye syndrome, and blurring of vision. The 4 clinical stages or the progression of the disease, you have diffuse papillary hypertrophy, macropapular, giant papular, and relatively intact disease, which we can see in the next picture. So these are the stages in ascending order. The bottom left picture is of giant papillae, which is caused due to lamellar separation. And the bottom right picture is caused due to, it is the resolution of the stage, which has a characteristic cobblestone appearance. These are the stages of limbal disease. So you have sparse limbal papillae, Horner-Trantas dots, extensive papillae, and the final stage of resolution. These are the stages of keratopathy. So keratopathy, these are the signs that you can observe while examining a patient. So as you can see in the picture, the purple demarcation, which I've marked in purple, this is called a pseudogernotoxon. So pseudogernotoxon is caused due to deposition of lipids and is usually seen in the limbal area, seen in children. Along with this, you have Horner-Trantas dots. Horner-Trantas dots, like I said before, mentioned before, this is caused due to deposition of eosinophils and macrophages, again in the limbal area. Along with this, you have epithelial macro erosions, plaques, subepithelial scars, shield ulcers, Demi-Morgan sign, and Maxwell-Lyon sign, which is a ropey discharge. Other manifestations include peripheral superficial vessel ingrowth, keratoconus, and herpes keratitis. Keratoconus is one of the major major manifestations in VKC, which is of public importance. It is caused due to excessive rubbing and itching of the eye, as well as chronic inflammation, where the cornea becomes cone-shaped. It manifests in early childhood and leads to refractory errors, gradual degeneration of cornea, and eventual blindness, and it usually present bilaterally. The management is to avoid exposure to allergen as much as possible and to avoid rubbing of the eyes, because rubbing of the eyes can actually lead to this keratoconus-like presentation. Corrective lenses such as astigmatic or toric lenses can be prescribed to correct these refractive errors. Now, the sequelae of VKC, you have shield ulcers, which is seen in untreated cases. You have a plaque of fibrin and mucus deposits over the epithelial defect with neovascularization, usually seen in 3 to 11 cases. Differential diagnosis includes atopic keratoconjunctivitis, allergic conjunctivitis, and giant papillary conjunctivitis. The differentiating feature is that in papillary conjunctivitis, the papillae are more than 1 millimeter in diameter and are mechanically induced by contact lenses or prosthesis. Now, a management of any acute case of VKC, cold compress will always be the first line of treatment. Along with this, you can give topical steroids in acute, severe, or exacerbated cases. Like with any other management based on steroids, the dosage should be gradually tapered to avoid long-term complications. In VKC, we are concerned with increased IOP, secondary or open-angle glaucoma, and cataracts. There are also anti-inflammatory drugs we can give, like mast cell stabilizers, antihistamines like cetirizine, imidazoline, levocabastine. Cyclosporin and other calcineurin inhibitors can also be administered. Along with this, you can give supportive therapy like artificial tears, dark goggles, and cold compress. This is the current demographic trends of VKC in India. So it's mostly predominant in the months between April to September, like I said, late spring and summer season. Most of them belong to rural areas because of increased exposure to animal waste, pollen residue, etc. Majority of the cases are of bulbar variety, which is seen in 42% cases, followed by palpebral and mixed variety. It's a disease of the childhood, mostly occurring during school-going age, and male children are most affected. In eastern part of the country, bulbar type is most common, and overall, more than half the patients present with corneal involvement. Thank you.
Thank you so much. Is this the first presentation?
No, ma'am. This is the 5th presentation. I think I presented after. This is the 5th presentation.
Dr. Manisha Nada and I have asked to log in at 5:45 p.m. Dr. Nada, you there, no?
Yeah. I'm there, and I've seen this is the first one I saw. I thought some other judge would be there.
Yeah, I've also seen this only the first. Are there any other judges? Good evening to you.
Good evening. Yeah.
Okay.
I am Dr. Shati Mojumdar.
Okay,
That is perfectly fine.
The
Dr.
first
Manisha?
judge is Professor Suchitra Mojumdar. I think her audio is not working properly.
And actually, we are not supposed to be in this hall. Dr. Nada and I were added, so I think we'll leave from here. We were supposed to be in hall 3. We got a message
Okay, I
from
think
Dr.
this is
Samantha.
hall 1.
Oh, yeah. No, he told us to log in here, but Dr. Nada, I think we can log out.
It is perfectly fine. If we were supposed to be there, I think I got a message that we should be in hall 1 by 5:05. And I think only one judge is there. Paper, I suppose.
No, but we have come late, no? So then we should go back to hall 3 or see something else. I don't know. I think I'll leave. You just see whether you want to stick on.
No, that won't be just, I think. Because
because it's the 5th presentation, no? We have come only now.
5 are over. So I think Dr. Swati can continue doing it. That would be.
So thank you so much, Dr. Swati. We'll check in hall 3 if something is going on, because Dr. Samantha told us here, but then initially we were told hall 3. So okay, thank you. Bye bye.
Thank you so much.
Only 2 speakers are left. Okay, thank you so much.
Okay, thank you.
Thank you so much.
Good evening, ma'am. Now it's my turn. 6th number, Om Kumar Sahu.
Om Kumar Sahu. Okay. Please start.
Is my slide visible?
Yes.
Good evening, everyone. I am Om Kumar Sahu from AIMS Raipur, and here I am going to present on the topic cystoid macular edema. So, first of all, introduction. Cystoid macular edema, it is a macular condition in which there is collection of fluid in the outer plexiform layer, also known as the Henle's layer of the retina, centered around the foveola. As we can see in the diagram, there are 10 layers of the retina, and in that the outer plexiform layer, when fluid gets accumulated, it leads to this condition, and it is the leading cause of central loss vision in the developed world, owing to its association with a number of disorders that we are going to see further. Pathophysiology. Basically, in our retina, there is an intrinsic balance between the osmotic pressure, hydrostatic pressure, capillary permeability, and tissue compliance. So, whenever there is some sort of imbalance between these factors, where the causes are vitreomacular traction or inflammation, this leads to the development of this condition. And why this layer is that outer plexiform layer is involved? It is because it is a watershed area that exists between the retinal and the choroidal circulation. Therefore, due to its relatively avascular nature, the fluid gets accumulated in this location. So what happens? Two initiating stimulus due to various causes can start this process, like first vitreomacular traction. There is incomplete posterior vitreous detachment followed by anterior to posterior traction forces on the macula. So there is stress at the Muller cell end feet, and there is a release of factors like fibroblast growth factor, vascular endothelial growth factor, platelet derived growth factor. Similarly, inflammation can also lead to release of intravitreal cytokines, which will increase the retinal vascularity. So basically what happens, all these factors will lead to breakdown of the inner blood retinal barrier, and there will be fluid accumulation in the outer plexiform layer of the retina. Coming to the different etiologies, it is very commonly seen in the post-operative cataract patients, presenting as Irwin glass syndrome, an inflammatory process that occurs in about 20% of the after 20% of the cataract surgeries, 6 to 10 weeks post-op, and they often resolve spontaneously within 6 months. But if many times it persists and it needs correction. Other surgeries include penetrating keratoplasty, glaucoma filtration surgery, retinal detachment surgery, pars lana vitrectomy, ocular laser therapy like pan-retinal photocoagulation, laser capsulotomy can also lead to this condition, and topical ocular drugs like prostaglandin analogs and epinephrine, dipiveprin, they are also responsible for the development of this condition. So many drugs and many of our treatment modalities may present this complication. So aphakic are also more prone to these medications. Coming to the diabetic retinopathy, it is also an important cause of, due to leakage from the microaneurysms at retinal capillaries, causing cystinate rings of hard exudates or lipoprotein deposits. And diabetic macular edema is the most common cause of loss of vision in the NPDR type of diabetic retinopathy. Apart from that, other causes are central retinal artery occlusion, branched retinal artery occlusion, Coats disease, and Eales disease. Intraocular inflammations like uveitis is the most frequent cause of CME. Apart from that, retinal dystrophies like retinitis pigmentosa, retinomacular, vitreomacular traction syndrome, intraocular tumors like cavernous hemangioma, malignant melanoma, and other miscellaneous causes are also responsible for this. How the patient will present is the patient will present with decreased visual acuity, metamorphopsia, micropsia, photophobia, etc. with these symptoms. Investigations that we are going to do for these patients, first of all, apart from the normal clinical examination, we will proceed to ophthalmoscopy. We will see loss of foveal contour, retinal thickening, a yellow spot at the center of the fovea. It is described as typical honeycomb appearance of the macula due to the cystoid oval spaces. And apart from that, associated disease which the patient has, like for example in diabetes, the associated retinal morphology will be visible. Fundus fluorescent angiography can be done, which shows characteristic flower petal appearance or petaloid appearance due to leakage and accumulation of dye in the macular area. Optical coherence tomography, OCT, we see loss of foveal depression, intraretinal area of decreased reflectivity, and round optically clear regions or cystoid spaces are visible, and overall retinal thickening is seen. Long-standing CME can ultimately lead to lamellar macular hole. And coming to the treatment modalities that we have, NSAIDs are proved to be very beneficial due to their anti-prostaglandin and anti-inflammatory action, which are responsible for blocking the pathogenesis of this condition. It's most common prophylactic treatment that we give for CME patients, like after intraocular surgeries, very commonly after cataract surgeries. Ketorolac or diclofenac are used topically pre and post-operatively. Corticosteroids also act to this inflammatory, anti-inflammatory action and suppressing all the cytokines, edema, and macrophages. So use of intraretinal triamcinolone has been increased due to its potent action against refractory CME, secondary to diabetes mellitus, CRVA, and other inflammatory conditions. Acetazolamide is also used, which is a carbonic anhydrase inhibitor. Anti-VEGF drugs, these are now the first line of treatment. They block the leakage by decreasing the vascular permeability. They are helpful in diabetic CME and other hypoxic vascular conditions. These are all the medical treatment. And then we come to the laser treatment. We have focal grid laser photocoagulation, which can be used. It promotes the formation of tight junctions between the retinal pigment epithelium and reduces the O2 demand and increases oxygen perfusion from the choroid. So thank you. With this, I'm concluding.
So Om.
Yes,
Om.
ma'am. Yes,
Yes.
ma'am.
What is the normal retinal thickness at macula?
Yes, ma'am. Sorry.
What is normal retinal thickness or macular thickness? What is the normal range? Because there is thickening, no?
Yes, ma'am.
Okay. Now, what is the why this cystoid appearance? This typical cystoid appearance?
Due to the accumulation of fluid in that layer of the retina, outer
But it
plexiform
is not
layer.
cystoid. I mean, it's not the flower petal type. The space is not flower petal type, but after accumulation, it takes up this pattern.
Yes, ma'am, because there is a central depression. So surrounding that, in that macula, we have a central, very thin area, and surrounding that, when fluid accumulates, so it gives central depression, like emerging of petal appearance, as in case of a flower. So that's why we have.
So in case of diabetic macular edema, does it give the cystoid appearance? No. Okay. Now you have mentioned micropsia and metamorphosia. What is micropsia? Yes. Why this this micropsia occurs?
Micropsia is basically whatever the length of the object, it seems to be smaller.
Why?
And
why?
metamorphosia is
now,
yes,
why there is micropsia?
Ma'am, due to that fluid, there is change in the refractive index, and there is further short diminution of the object length.
No, no, that is not. And again, how do you check metamorphosia?
The person will complain of curviness in the lines. Straight lines will be visible as curved or rounded lines. So we can check this by doing our vision tests and other tests.
What is Amsler grid, Dr. Sahu?
Yes, ma'am.
What is Amsler grid?
Amsler's grid. Yes, ma'am. That is sorry. Yes, that was a instrument by which we can diagnose this metamorphosia, or even scotoma can also be diagnosed. It is basically square-shaped grid, and by that we can monitor the metamorphosia. It includes straight lines, and the patient will appreciate it as curved lines and if not straight squares.
Very nice.
How many charts are there in Amsler grid? Dr. Om?
Yes.
Uh, chart.
Okay, okay, fine. Fine. Thank you. Thank you very much. Okay, next, Dr. Tiripurna.
Dr. Swati?
Yes, ma'am. Myself, Tripura Sundari.
Hello.
Hello. Can I speak to Dr. Swati?
Yes, ma'am. Can
Yes,
you hear
yes.
me right now?
Dr. Swati, I'm there in the group, but we are not going to give marks. Hai na?
Okay, fine. Okay, fine.
Yeah,
yeah. Well, you can participate also. I mean, you can give
Yeah, I'm
marks.
participating.
You can award
I'm
marks.
asking. Yeah, I'm
You
asking.
can award marks. We can sum up later on.
Yeah, sure.
So can you continue?
Ma'am, this is Tripura Sundari. Can I share the screen right now?
Yes, please.
Sati, you have finished? Hello?
Hello? Dr. Suchitra ma'am.
No, I'm Dr. Chandna. Is it finished?
Oh, no, it's not finished. Only one last speaker is there. Only
Please
one
continue.
speaker is left.
Please continue. We have to start the next session.
Okay. Actually, there was some technical problem. That's why it is delayed.
Okay.
Dr. Tiripurna, please continue.
Good evening, ma'am. This is Tripura Sundari, a third-year MBBS student from Government Medical College, Omandarat, Chennai. My topic is about anatomy of anterior chamber angle. Here's a list of line diagrams which I've used to explain the anterior chamber structures. Starting with, we have this cornea and the sclera, and their junction being the limbus. A groove on the inner side of the limbus is known as the scleral sulcus, and the anterior most projection being the scleral spur. The scleral sulcus lodges the trabecular meshwork. This trabecular meshwork from inside out is divided into three, namely the uveal trabecular meshwork, the corneal trabecular meshwork, and the juxtacardiac trabecular meshwork. This scleral sulcus in turn also lodges a Schlemm's canal just behind the trabecular meshwork. This Schlemm's canal continues as the collector's channel, the aqueous vein, and then the episcleral plexus. Thus, the aqueous from the anterior chamber drains through the trabecular meshwork, through the Schlemm's canal, and the collector's channel, then the aqueous vein, and the episcleral plexus, eventually draining into the cavernous sinus. Here's a 3D anatomical representation of the structures. The ciliary body continues as a ciliary body band just behind the scleral spur, and then the iris, it attaches itself into the ciliary body band, and this structure is known as the iris root or the root of iris. Thus, there are 5 structures in the anterior chamber angle. From anterior to posterior, it's Schwalbe's line, trabecular meshwork, scleral spur, ciliary body band, and the iris root. Let's talk in detail about its structure, the first being the Schwalbe's line. It forms the posterior peripheral limit of the descemet membrane in cornea, and it is also a transition zone between the trabecular meshwork endothelium and the corneal endothelium. Moreover, in gonioscopy, the corneal white light ledge helps us identify the Schwalbe's line, where the anterior and the posterior beams converge exactly at the Schwalbe's line, helps us identifying it eventually. The Schwalbe's line may or may not be pigmented, and it also is an important landmark because normal vessels and tissue does not cross it. So in case of neovascularization in peripheral anterior sinic cave, if the blood vessels cross it, we can identify this by a simple gonioscopic finding. The next being in gonioscopy, the Schwalbe's line is seen as a fine white ridge as seen in this picture. There are different disorders related to it. The first being the pigmentation anterior to Schwalbe's line, as seen in pseudoexposition syndrome. This is known as Sampolisi's line. The next being posterior impaired toxon. It is associated with Axenfeld-Rieger syndrome, where there's a thickened trabecular Schwalbe's line seen. In this picture, you can see that the Schwalbe's line is thickened both nasally and temporally. The second structure is trabecular meshwork. It is a spawn seed-like connective tissue, which is divided into 2 layers. The first being the anterior non-pigmented layer and the posterior pigmented layer. The anterior non-pigmented layer is non-functional, whereas the posterior pigmented layer is functional. And it is in turn divided into 3, as I already mentioned: the uveal trabecular meshwork, the corneal scleral, and the juxtacanalicular trabecular meshwork. The uveal trabecular meshwork has large spores, whereas the corneal scleral contains elliptical spores, and the juxtacanalicular contains cribriform layer, which provides a maximum resistance to aqueous outflow. Therefore, as we move from the inner to the outer side, we get to know that the size of the pores decreases, thus facilitating active filtration of aqueous and the drainage of aqueous humor. The third structure is scleral spur. It is composed of a group of fibers, namely the scleral roll, and it also forms a posterior border of the trabecular meshwork. It is a site of attachment of the longitudinal muscle, here seen as the Brooks muscle. In this Mason trichome stain, the longitudinal muscle is attached to a particular point, which is depicted by the black arrow. It is nothing but the scleral spur. The white arrow represents the Schwalbe line. This scleral spur on gonioscopy is seen as white to yellowish line. The first structure is ciliary body band. It is seen as a gray to dark brown band in gonioscopy, which is it is also wider in myopes and aphakics, whereas it is narrow in hypermetropes. This is a picture showing the broad ciliary body band in high myopes. The last structure being the root of iris. It is a peripheral insertion of the iris, which is thinnest at its insertion. If this insertion is, if the ciliary root of iris doesn't get inserted itself into the ciliary body band and instead inserts into the scleral spur, it forms a condition known as plateau iris configuration. Moreover, in cases of pupillary block, hyperopia, and tumors, convex iris configuration is seen. In Asians, that is we hereditary have a thick iris root, which increases the risk of angle closure glaucoma. And if there is a pathology in the iris root, it may lead to iridotrabecular contact, or that is opposition, and Ineke formation. As a whole, these are the 5 structures in the anterior chamber angle. The first being Schwalbe line, seen as a white ridge. The next being trabecular meshwork, which has 2 layers, the anterior non-pigmented layer and posterior pigmented layer. The scleral spur and the ciliary body band, and the last being root of iris. There are various tests to assess the angle of anterior chamber. The first being the flashlight test, Van-Ferrich's test, gonioscopy, ultrasound biomicroscopy, and the latest being the optical coherence topography. There are different grades in gonioscopy. These are different grades. I'm here, I will explain in detail about the Schafer's grading. These are the angle structures. If we see like the clip art presented here, if we see the angle structures in this way, we will be able to see that there are different grades assigned to it. There are grades from 0 to 4. The 4th grade being all 4 structures of the angle of anterior chamber is seen, and this helps us to conclude that the angle is wide open. As we move from grade 4 to grade 0, the angle keeps reducing, and the structures being seen, each structure is not seen. So in the last grade, that is grade 0, none of the structures are seen, and the angle is concluded to be closed completely. The importance of knowing the anatomy of anterior chamber angle is to classify the type of glaucoma we have. It is also to assess the angle recession, to check the extent of neovascularization if there is any. We can also do this for getting evidence for inflammation, to check for degenerative developmental anomalies, and for planning the type of surgery and treatment. It also helps us in evidence of neoplastic activity. Thank you.
Well, Tirupurna. Your name is Tirupurna, no? Let me get
I'm Tripura Sundari.
Tripura.
Tripura, yes, ma'am, Tripura.
Okay, fine. Okay. Now, Tripura, can you tell me, with the help of a flashlight or slit lamp, can you visualize anterior angle structures?
Ma'am, we can see till the Schwalbe line and the trabecular meshwork, but we won't be able to see the posterior structures. In slit lamp, ma'am?
No, without using any gonioscope. Right? Or mirror. Can you visualize the angle structure?
We can only see till the trabecular meshwork, or we can only see. No, ma'am, I'm not sure.
No.
We won't be able to see, ma'am. Yeah, we can't see. Yes, we can't see.
Why?
Ma'am, the angulation is different, and moreover, in slit lamp, we won't be able to see magnified structures. Moreover, slit lamp is used to see the fundus and the macula.
No. Actually, yeah, this is due to total internal reflection, no? So, without using any gonioscopic mirror or any instrument,
Yes, ma'am.
you can't
Without using the
visualize
gonioscopic
angle
mirrors, we won't be able to see.
Yes,
Yes,
right.
ma'am.
Now, following, suppose you have done, well, you are third year student, no? Third year MBBS student
Yes,
or
ma'am.
MS? Third year MBBS student. Right?
Third year MBBS student, ma'am.
Okay. So, can you tell me what are the visual field defects of POAG, primary open angle glaucoma? Typical visual field defects.
Primary open angle glaucoma, ma'am.
Yes.
Visual defects, we'll
Field
see
defects.
that there'll be eye software contraction.
Yes.
Ma'am?
Yes, yes, of
Shall I
course.
continue?
Yes.
It will start from eye software contraction, and then it leads on to the sparring of the blind spot, and from there it leads to the paracentral scotoma, and then to cedal scotoma, and then to arcuate scotoma. Arcuate scotoma is also known as Verem scotoma. Then from there we can go. It will lead to double arcuate scotoma, and in this case we have Roney's central nasal step, and if all these structures are being involved, it will finally lead to tunnel vision, and even if the tunnel vision is lost, then the temporal field will go at last. So the central vision is the last go.
It's very good. Very good.
Open angle.
So, once you have diagnosed a case of, suppose, open angle glaucoma, primary open angle glaucoma, should you do a gonioscopy during follow-up?
Ma'am, it is actually kind of contraindicated because we Asians have a thicker root of iris. So if we dilate the eye, yes, ma'am. If you dilate the eye,
No,
the
we are
iris
not
dilation
dilating.
can lead to acute.
We are not dilating. I am asking whether you should do gonioscopy during follow-up visits in a case of diagnosed primary open angle glaucoma on treatment. We should do.
Yes,
because he or she may
we can
develop
check- yes,
secondary
ma'am, we
angle
should.
closure glaucoma, right? So we should do.
Yes,
No, that
ma'am.
was
Yes,
nice.
ma'am.
Okay, fine.
Yes,
Okay, Dr. Nada, or I think.
Thank you, ma'am.
Yeah. Well, any judges there? Dr. Shuchitra Majumdar, can you ask any question? Or Dr. Nada, I think she was present during the previous presentation.
Yes, Dr. Swati.
Can you, do you want to
This
ask any
presentation?
question?
Yeah, this presentation was very nice. Last presentation on this this glaucoma. Very nice. She showed good videos, depicted and answered your questions very well. So you may now give marks, and the final marks you can give it to Dr. Channa.
Ma'am, I have not presented.
Even me, ma'am. Good afternoon, ma'am. Ma'am, I am also left.
Okay. Right. Then continue. Dr. Swati. Dr. Swati.
Hello. Hello. Good evening. Good evening, sir. Good evening, all.
Good evening, sir.
Good evening. So in this particular hall, all the papers are over now.
Sir, 2 papers are left, sir.
Okay, so carry on with all these 2 papers, and then declare the results of this hall. How many papers are there in this particular hall today?
Sir, about 10 papers have been presented. Dr. Swati was
Yes, good. So amongst these 10, you select 2 papers as best paper. Okay,
right,
2 papers, and then we will go on with the best of the best session. From each of the hall, we have found out 1 paper for 5 candidates. For 5 candidates, 1 best. So in your hall, when you have got 10 candidates, you select 2 best ones. Okay, and then ask them to sit over here. And I also request you also to sit over here, and all the other judges will also join with us. And all the best candidates will again present their papers here, and we will find out the best of the best. Do you follow me? Thank you very much. Please start.
Sir, for the next session, I won't be available, sir, because I was...
Okay.
Sir,
Then we will be there. No problem. We will be there. we will be there. Please be kind enough to finish this session and select the 2 bests. Okay.
Sure, sir. Sure, sir.
2 best. Yeah. So, and it's a humble request to each of the presenters that keep your presentation limited within only 6 minutes, not more than that. Then you'll be disqualified. Only 6 minutes.
I would like Dr. Swati to be here. I think she has left. Dr. Swati.
Yes.
Swati Majumdar, sir.
Yes, Dr. Swati. So please start with the presentation of this particular session here. Who are yet to left among these 10 presentations? Who are yet to present?
The 2 names. Message करने के लिए बताइए. Just tell them to message us the 2 names.
Who are yet to present?
Dr. Samar Thakur is to be present now. He is going to present.
No. Dr. Samar Thakur has been selected as the best from other session. They will talk in the best of the best session. That is some other session.
Okay, sir. Right, sir.
Is there anybody?
Sir,
is there anybody left in the first session?
Sir, Adrija Ghosh, sir.
Adrija Ghosh is from the other session.
Now they will start.
Other session. We just like to know the result of your session, this first session. We like to know. I am telling you the names. From 5 halls, 5 best speakers have been taken up here. And from this particular hall, we have not yet received the name. Who is from this hall? ওরা ভুল বুঝছে, ওরা ওদিকে আবার ধরতে শুরু করেছে। এই ওই কাগজটা দেখি আমার লিস্টটা। From hall number 1 still pending. From hall number 2 Adrija Ghosh. From hall number 3 Dr. Samar Thakur. From hall number 4 Miss Niveda. From hall number 5 Miss Nikita. From hall number 6 Miss Dhaneshwari. So they have been called here and they are here. They will wait. And then we will start the best of the best. Who is selected from this hall? As you have got 10.
Yes, sir. So Dr. Swati is to give you the result from
Yes. Then we will declare and ask those to be in this hall. And then we will start this session here.
আচ্ছা ঠিক তোমার যদি অসুবিধা থাকে তাহলে ছেড়ে দাও হ্যাঁ অসুবিধা থাকলে বাদ দিয়ে দাও হ্যাঁ
you just send the 2 names
আচ্ছা ঠিক আছে তুমি থাকো তাহলে থাকো
and send the 2 names
তুমি নাম দুটো পাঠিয়ে দাও নামটা পাঠাও শুধু নাম
Professor Monisha Rothi are here.
So she is not there. She was there for one talk only. She left that and
Yes, Professor Monisha Rothi, they will come here as the judges for the best of the best session. Myself, Dr. Chandra Chakraborty, Professor Romar Das is there. All are there. Select the best of the best. Oh, okay. And the best one will get 10,000 rupees cash prize.
very nice.
As per our declaration, and a silver medal.
Very nice.
And the HOD will also get some beautiful memento and other things.
Rajan Srivastav and Sripurna Sundari.
So in hall 1, Rajan Srivastav, and Siguna Chaudhuri has been selected. Sundari. Hey, UG का list दीजिए तो. UG का list कहाँ है?
उधर के बोलूँ फोन कर
क्या हो? सुनो तुम इंग्लिश पढ़ना जानता हो? क्या बोला आपको? क्या मांगा मैंने? सर यूजी ये क्या लिखा है? इसी के लिए हम लोग इनको नहीं लेते हैं
ना, ये आपका
सुनो बाबा,
एक मिनट रुकिए.
सुनो.
No, don't do it.
Service should be perfect. Yes.
बस ठीक है, जो इतनी ऐसे.
Yes. So बोले कि वही देखना चाहिए.
ये है.
So क्या नाम है? राजन. ना राजन क्या बोला?
राजन श्रीवास्तव.
क्या नाम है? राजन श्रीवास्तव. in hall 1. In platform 1 ki Rajan Srivastava আর কি?
Purna Sundari.
পূর্ণা সুন্দরী। তাড়াতাড়ি করছেন কেন? এত তাড়াতাড়ি করবেন না, তাড়াতাড়ি করলে সব ভুলে অনেক সময় আছে। এই করে পরে জানেন তো এই নিয়ে অনেক কথা উঠছে, তার টাকা পেলো না, সে এলো না, তাকে নাম্বারটা জানা হলো না, এই প্রচুর ঝামেলা। পূর্ণা সুন্দরী বেস্ট, এই নিয়ে প্রচুর ঝামেলা। আমরাই দেখে বলে দেবো কোন লাস্টে, প্রাইমারি তো হয়ে গেছে, এটা নিয়ে ভাবার কিছু নেই। পূর্ণা সুন্দরী আর কে? আরেকটা কে?
Rajan Srivastava.
জোরে জোরে বলে দিচ্ছি, শুনে নেবে। রাজন শ্রীবাস্তব, রাজন শ্রীবাস্তব, এটা best. So once again, I like to declare the names of the competitors of this particular session. Do you hear to me?
Yes, sir.
Yes. From hall number 1. From hall number 1. Hall number 1. Tripura Sundari, Government Medical College, O1 Dwarar, Government IE Estate, Chennai. Tripura Sundari here?
Yes, sir. I'm here.
Tripura Sundari B, yes. The second one from platform number 1, Mr. Rajan Srivastava from All India Institute of Medical Science, Raipur, Chhattisgarh. You are here?
Yes, sir.
Thank you very much. Now from platform number 2, only one candidate because they have got only 5 people there. Miss Adrija Ghosh. Adrija Ghosh from Medical College, Calcutta. Are you here? Miss Adrija Ghosh is here? Miss Adrija Ghosh is here? Miss Adrija Ghosh. Mr. Samod Thakur from Himachal Pradesh, from RPG Medical
Yes, sir,
College, Tanta. You are here?
Yes, sir, I'm present.
Yes, from platform number 3. From platform number 4, Miss Niveda Sara Tensing,
Yes,
Amrita
sir, I'm here.
Institute
Yes,
of
sir.
Medical Science,
Yes, sir. Yes, sir.
Kochi, Kerala. You are here. Okay. From platform number 5, Miss Nikita Bash, Bharati Vidyapit Medical College and Hospital, Sangli, Maharashtra. Are you here?
Yes, sir.
Thank you very much. Then from platform number 6, Ms. Dhaneshwari Matre, Bharati Vidyapit Medical College and Hospital, Sangli, Maharashtra. Are you here?
Yes, sir. Yes, sir.
So here is Professor Samanta. Just a bit. উপরে 102 নম্বর ঘরে আসবে দোতলায়, ঠিক আছে? আমার কাছে আছে, আচ্ছা আমি খুঁজে দেখছি, ঠিক আছে? বল টেলিফোনের চার্জার, বলো টেলিফোনের চার্জার, ঠিক আছে? ওকে। So here we have a greetings from the Forum of Optal Professors of India along with the Association of Community Ophthalmologists of India. With the Forum of Optal Professors of India, it is a forum of professors and associate professors of all the government and non-government medical colleges in India, whether the in-service or retired professors and associate professors. We have organized this particular webinar academic competition for an exercise amongst all of you to give some presentation. But unfortunately, many of you have got no innovative ideas, only copied and made so many slides. This is unfortunate. So in future, we like to have very salient, innovative ideas, what you can give some impression to us. Now, each one of you will get a certificate and a medal which will be sent to your areas by courier post, as well as the best one of each of the session will also get some cash prizes. And now we will select the best of the best. From these 6 halls, we have taken 7 candidates. Each one will present They are same. They are same presentation what they have presented only an hour back. But you must stick to the point. Only 6 minutes and only 10 to 15 slides. Then we will select the best one. The best one will get a cash prize of 10,000 rupees, a gold, silver medal, as well as the HOD of his or her medical college will get a special memento and citation. So, my dear students, please to join in this particular session to select the best of the best. Only 6 minutes presentation. Mind it. And there will be only 2 questions from any of the judges, very small questions. So we like to finish each one of you by 8 minutes, and then you will go on to the next. So from hall wise, we will go one after another. I would request Dr. Chandana Chakraborty, no, Dr. Chandana, Dr. Inder Mohan Rustagi, Professor Inder Mohan Rustagi, Professor Manisha Rathi, Professor Suchitra Mojumdar, and Dr. Swati Mojumdar, Dr. Ruma Das, and Professor Pragati Garg, as well as Professor Pragya Panda, Professor Kumudini Sharma, and Professor Manisha Rathi, to be with Manisha Rathi and Professor Manisha Tada, to be all with us and to give the numbers on their own and to send it to me over WhatsApp to select the best of the best. The best of the best will be declared on day after tomorrow during our inaugural session, and will be informed to you over WhatsApp, not today. On 2nd April morning, we will declare the name of the best of the best. So let's start our presentation. So from platform number 1, may I call upon the first one, Mr. Ranjan Srivastav from All India Institute of Medical Science, Raipur, Chhattisgarh, to present his presentation. Please take to time.
Yes.
আমি এখান থেকে বলে দিই তারা এই ওই গন্ডগোলের স্টার্ট কি হয় আপনাকে বলি এদের যে
Sir, is my slide visible? Hello. Hello. Am I audible? Can someone please confirm? Hello.
Yes, you are audible.
Okay, can I start now? Can I start? Hello, can I start now? Please, if someone could respond, can I start now? Hello. Can someone confirm if I'm audible and can I start now?
Yes, you are audible.
Can I start? Uh, can I start now, please? Someone?
Rajan?
Yes, ma'am.
Yes, you can start.
Okay, okay. Thank you, ma'am. A very warm and respected good evening to esteemed professors, eminent members, and one and all. This is Rajan Srivastava from AIMS Raipur. With your kind permission, starting my presentation. So first, I have 4 pictures on the screen in front, and it's quite evident that what's common in all these 4 pictures. Yes, they all are visually impaired. But what's unique is that they are showing 4 different aspects of a common intervention, and that's called as rehabilitation. And that is my topic for presentation today. Rehabilitation of visually impaired. Now, blindness in simple terms is inability to see. So does it only have a physical dimension? No, it's quite evident that no. It's affect all the physical, mental, as well as social dimension. Now, WHO has defined blindness as vision less than 3/60 and or a corresponding visual field less than 10 degree in the better eye with the best possible correction. Now, it is estimated that globally nearly 1 billion people are visually impaired. And in India, according to the National Rapid Survey on Blindness 2006-7, it showed that prevalence of blindness was 1%, which though dropped down to 0.36% in 2015-18, but still comparing with the demographic status, it's still quite high. So what are the causes of blindness? So we have cataract, we have refractory errors, glaucoma, 1% is contributed by surgical complications or opacities, and others. Now, what's the cause behind such high rates? Now, with 30% of blind in India are said to lose their eyesight before 20 years of age. The major causes being malnutrition, that's not only related to vitamin A deficiency, but also to the other infections of childhood like diarrhea, measles, protein energy malnutrition being one of the major causes. Then occupational hazards like exposure to dust, airborne particles, fumes, gases, electrical flashes. Now, it has been seen that poorer classes have twice more prevalence of blindness than well-to-do classes. So what could be the reason? So it is basically due to ignorance, poverty, low standard of personal and community hygiene, inadequate healthcare services availability, as well as accessibility. Now, which in 2020, the right to see was basically enacted by WHO in 1999 with an objective to assist the member countries in developing a sustainable system to enable them to eliminate avoidable blindness from major causes by the year 2020. And when we talk about prevention, it goes under the heading of primary, secondary, and tertiary prevention. And it is under tertiary prevention where we have this concept of rehabilitation. Now, what is rehabilitation? So it's basically a clinical therapy or a non-clinical training to provide those who are blind or low vision people with skills and tools so that they can maintain a safe, independent, and active lifestyle and can participate in education, can travel safely, meet their career goals, and can enjoy activities. So we have educational, vocational, social rehabilitation, as well as daily activities and mobility. Now, if we talk about educational rehabilitation, then WHO estimated that out of 6 million blind or low vision preschool and school-going age children, nearly 80% of them live in those developing countries where only 1 out of 10 has access of basic education, which is basically due to lack of properly trained teachers, education facilities, inability to identify all those who are visually impaired, and lack of awareness as well as limited favorable policies. So the various modes of educational rehabilitation we have by making dedicated schools for blind with proper all the facilities as well as properly trained teachers, special calligraphic alphabetical orders in the form of the braille alphabets, which have all these letters which they can read. We have some modern technologies as in the form of electronic braille system, the electronic keyboards made up of braille, and we have another important newer technology as a sound system, which basically have this webcam that perceives these visual impulses, converts into auditory impulses, and received by the auditory cortex, and then it synchronizes with the visual cortex and make the patient able to see what is in front. Now, once the patient gains education, the another important aspect is that the another important question that the patient asks that what is his career with visual impairment? What a blind person can do for a career? So there comes the role of vocational rehabilitation. So there are various kinds of jobs like teaching, guidance counselors, psychologists, physical therapists, rehabilitation teachers, and as well as customer service representative. Now, the implementation of a Person with Disability Act 1995, which mandates around 1% of job for people who are reserved, who are visually impaired in government and private sectors, have paved the way for those who are visually challenged. So we have examples for these, such as this lady working in a customer care service and a lady who is self-employed. We have several examples of it. Now, after this, no one wants to get dependent on other for their basic necessities, for which we require rehabilitation for daily activities and mobility, of which the Third Eye for Blind project is an innovation which solves this problem with the help of certain wearable bands that produces ultrasonic waves which notifies them of their surrounding with buzz or vibrations. So we have these bands being worn over different parts, and they basically vibrates and make the person aware of their surrounding. So in this, we have this mini camera, the embedded sensor of motions, the ultrasonic sensors which recognizes the object which is nearby. A modular form of this, in which we have in the form of wearable goggles, wristbands, and the modern 6. Now, another main aspect is mental and social rehabilitation. Now, in many instances, the situation of those who are visually impaired is basically as a result of misconception about their capabilities. In the developing countries, where these resources like training and technological resources are very much limited, these visually impaired individuals are often excluded from their workplace. Why? Because among the general public, the notion is that they're not capable of doing anything. As a result of which, okay, they're excluded from the workplace, from the society, they become disheartened, resulting in social as well as economic isolation. So our basic aspect should be to create awareness among the general public and community, and we should make the people aware, make the people understand that blind are not able to see anything, but they but they do their work greatly. Yes, I haven't put certain examples here, such as this great personality, Miss Helen Keller. Another example I would like to quote of Mr. Louis Braille, the inventor of the Braille system. Then another very famous example of Mr. Ravindra Singh, a great music composer and a singer, and it's just not possible to list all the great albums and hits he has given. And quoting out of many examples, my last example would be of this person, Mr. Ankur Dhama, the Indian Paralympic, who won several medals in national and international championship for running and two participated in the Rio Paralympic event, Mr. Ankur Dhama.
Sorry,
So
time is over. Time is over.
Okay, sir, thank you.
Mr. Rajan.
Yes, sir.
I have got only one question. Have you ever visited any blind school?
Sir, actually, from our
not actually, I like to know practically, because Professor Somen Mishra is your HOD. Have you ever visited any blind school?
So from our school, I've visited.
Huh?
So from my school, I've visited. From on the behalf of my school.
You have a beautiful presentation, but there is no big photograph of any blind of Chhattisgarh. All you have downloaded from the internet. So from next time onwards, you please try to put up any photograph of your locality, your hospital, of any of your presentation. Am I right?
Yes, sir.
Any any more question from any judge? Only 1 minute. Any more question from any judge? No question. So we like to move on to the next presentation by another best one of platform number 1. Ms. Thiripura Sundari, IB, from Government Medical College, Omandurar Government Estate, Chennai. Thiripura Sundari.
Yes, sir.
Please start your presentation, and you will be disqualified if it crosses 6 minutes time.
Okay, sir. So is my screen visible? So is my screen visible?
Yes, it is. Continue, please.
Good evening, all. This is Tripura Sundari, a third year MBA student from Omundra Medical College, Chennai. My topic is about anatomy of anterior chamber angle. Here I have a list of line diagrams depicting the structures, the first being the sclera and the cornea. Their junction, that is the sclerocorneal junction, is known as limbus. On its inner side, there's a groove-like shaped structure known as scleral sulcus, and the anterior most projection from this sulcus is known as the scleral spur. The scleral sulcus also lodges the trabecular meshwork. This trabecular meshwork from inside out is divided into three, namely uveal trabecular meshwork, corneal trabecular meshwork, and the juxtacanalicular trabecular meshwork. This scleral sulcus also lodges Lums canal just behind the trabecular meshwork, and it continues as the collector's channel, the aqueous vein, and the episcleral plexus. Thus, the aqueous humor from the anterior chamber flows through the trabecular meshwork, the Lums canal, the collector's channel, the aqueous vein, and the episcleral plexus, eventually draining into the cavernous sinus. This is a 3D depiction of the structures. The ciliary body continues as a ciliary body band just behind the scleral spur, whereas the iris gets attached to the ciliary body band, and this structure is known as root of iris. Therefore, there are 5 structures in the anterior chamber, and they are namely from anterior to posterior, it's Schwalbe's line, trabecular meshwork, scleral spur, ciliary body band, and iris root. In detail about the structure, the first being the Schwalbe's line, it is a transition between. Shall I continue, Mom? It is a transition between the trabecular meshwork endothelium and the corneal endothelium, and it forms the peripheral limit of the decimus membrane in the cornea. It can be seen in the gonioscope by the corneal wedge, which forms the anterior and posterior beams converge exactly at the Schwalbe's line, thus depicting the Schwalbe's line in the gonioscope. The Schwalbe's line may or may not be pigmented, and it forms an important landmark because normal vessels and tissue does not cross it. So, in case of neovascularization and peripheral anterior synechiae, with just a simple gonioscopic finding, we'll be able to diagnose the condition. In the gonioscope, the Schwalbe's line is seen as a fine white ridge, as seen in this picture. The next structure, there are certain conditions in Schwalbe's line. The first being in posterior embryo toxon, there's pigmentation anterior to the Schwalbe's line. This line is known as a Sampolisis line. The second disorder is the posterior embryo toxon, which is associated with the Axenfeld-Rieger syndrome. There's a thickened Schwalbe's line seen in this picture, and in here, the Schwalbe's line is thickened both nasally and temporally. The second structure is the trabecular meshwork. It is a sponge sieve-like connective tissue, and it is in turn divided into 2 layers, the anterior non-pigmented layer and the posterior pigmented layer. This anterior non-pigmented layer is a non-functional layer, whereas the posterior one is a functional layer. This functional layer is interdivided into 3, as I already mentioned, the uveal trabecular meshwork, the corneal trabecular meshwork, and the juxtacanalicular trabecular meshwork. The uveal trabecular meshwork contains large pores, whereas the corneal scleral contains elliptical pores, and the juxtacanalicular trabecular meshwork acts as a pubriform layer and provides a maximum resistance to the aqueous outflow. Thus, from moving from inside out, the size of the pores keeps decreasing, thus facilitating active filtration of the trabecular mesh, active filtration of the aqueous humor, and the outflow of aqueous. The third structure is scleral spur. It is composed of a group of fibers, namely the scleral rule. It forms the posterior border of the trabecular meshwork, and also it is a site of attachment of the Brooks muscle, that is the longitudinal muscle of ciliary body. In this Mason trichome stain, we can see the longitudinal muscle being attached to a particular point marked by the black arrow, that is the scleral spur, and the white arrow represents the Schwalbe's line. This scleral spur in the gonioscopy is seen as white to yellowish line. The fourth structure is the ciliary body band. It is gray to dark brown in color in gonioscope. It is wider in myopes and narrow in hypermetropes. Moreover, in this picture, we can see the ciliary body band, which is broad in high myopes. The last structure is root of iris. It is a peripheral insertion of iris, which is thinnest at its insertion. It inserts itself into the ciliary body band. Instead, if it inserts itself the scleral spur, it forms a condition known as the plateau iris configuration. Moreover, in conditions like pupillary work, hyperopia, and tumors, we can see a convex iris configuration. In V Asians, hereditary we have a thick iris root. Therefore, it increases the risk of angle closure glaucoma. Moreover, if the root of iris has any pathology, it may lead to iridotrabecular contact or opposition or synechiae formation. Therefore, there are 5 structures. From anterior to posterior, it's a Schwalbe's line seen by the white ridge, the trabecular meshwork by the anterior non-pigmented layer, and the posterior pigmented layer. the scleral spur with the white ridge, and the ciliary body.
1 minute more. 1 minute more.
These are the tests for the angle, to assess the angle, and these are the grades for the gonioscopic conditions. This is in detail about the Schaffer's grading. Here we can assess the angle by the structures seen. The grade 4 being, it concludes that there's a wide open angle, whereas in grade 0, none of the structures are seen, so it's considered to be, the angle is considered to be closed. This helps us find the amount of angle degrees present. For example, in grade 0, it's 0 degrees, whereas in grade 2, it's 20 degrees. From grade 2 to grade 0, it's considered as occludable angle. The importance. We should know the importance of all these angle structures to classify the glaucoma, to assess angle recession, to check the extent of neovascularization if there's any, the evidence of inflammation, to check about degenerative and developmental anomalies, to plan the type of surgery and treatment, and the evidence, and to search for any evidence for neoplastic activity. Thank you. So, so can I get back connected? Excuse me, sir. I finished my presentation.
Dr. Tripura Sundari?
Yes, ma'am.
What is ultrasound biomicroscopy? Do you know of it?
Ma'am, we have only read about it. I haven't seen ultrasound biomicroscopy yet.
Have you come across this word while you were reading the anatomy of the anterior chamber?
Yes, ma'am. While reading the gonioscopic, and also my guide. Still no.
আচ্ছা করতে কিছু বলছে কেউ বলছে কিছু কেউ কোনো কোশ্চেন করছে
Ma'am.
Right, it's okay. Yeah.
কিছু বলছে না
Well presented, yeah.
I have only read about it, ma'am. I haven't seen it but in person.
Doesn't matter, but you should be knowing a little bit because you have read, given such a nice anatomy of the anterior chamber. So that is why I'm asking this question.
Okay, ma'am.
What is a plateau iris?
Ma'am, plateau iris, the root of iris normally gets.
I think no more question is there. So can we switch over to other?
Next one, yes.
Can we switch over to the other speaker?
Yes, sir.
Ma'am,
it is
shall I
over.
continue?
May I call upon the other speaker?
Okay, ma'am.
The best
Thank you,
one
ma'am.
from hall 2. The best one from hall 2, Miss Adrija Ghosh from Calcutta Medical College, Calcutta.
Yes, sir.
Adrija Ghosh.
Yes, sir.
Start.
Okay, sir.
It's not audible. No sound.
A very good evening to one and all present here. This is Adrija Ghosh. I am a third-year medical student in Medical College, Kolkata. Today's presentation is about a profile of patients undergoing penetrating keratoplasty.
Yes, chana. Sound as chana.
Am I audible?
Sound as chana.
Yes, yes, you are audible.
Am
You
I
are audible.
Okay.
You are audible. Carry on.
This is about a profile of patients undergoing penetrating keratoplasty in a tertiary healthcare center of Eastern India. Starting off with the problem at hand, blindness, as we know, is a major health problem in developing countries like India. To give an idea about the numbers, 39 million people over the world are blind, and 246 million have moderate to severe visual impairment. Almost half of these cases could be prevented and some of them are not even addressed yet. These huge numbers are only projected to rise over the years due to the increasing aging population, lifestyle changes, slow epidemic of non-communicable diseases, and others. Looking at the problem in India, the major causes of blindness are cataract, refractory errors, glaucoma, followed by corneal blindness. 6.8 million people in India suffer from corneal pathologies, out of which 1 million have bilateral blindness. These pathologies require keratoplasty, which can be penetrating or lamellar in nature. Penetrating keratoplasty was the first surgical technique developed in the start of the 20th century. Corneal transplantation is the most common type of tissue transplantation made all over the world. However, there is a huge gap in the demand and supply of cornea, and there is an additional need of 25,000 to 30,000 corneas every year. The objective of this presentation is to study the clinical profile and main indicating conditions of the patients undergoing keratoplasty. This is a cross-sectional observational study conducted at a tertiary healthcare center. It included 93 patients from January 2021 to December 2021. Secondary data was available, and the variables studied were age at which they were undergoing the surgery, sex, religion, and the indication for the surgery. Out of the 93 patients undergoing keratoplasty, 65% were male, which is a ratio of 1.9:1. This is similar to the results observed in other studies all over the world. However, for a possible explanation as to why males are more prone to having corneal damages, it could be an exposure to outdoor occupation, agricultural trauma, or industrial trauma. Along with that, it could also be the fact that women in India all are still prone to negligence and have not been, maybe in a lot of cases in women are not even presenting to the OPD. And even if they are presenting, they're presenting at very late stages. A religious distribution of the data showed 63% were practicing Hinduism. Age distribution of the patient shows the mean age of the patient was 49 years with a standard deviation of 12 years. This is similar to the studies obtained in other parts. The youngest patient registered was of 17 years and the oldest of 73 years. As we can see from this bar diagram, the highest number of cases were present in 50 to 54 years of age. And the maximum number of cases, which is about 70%, were present in the age group from 40 to 65 years of age. This could be due to the other predisposing conditions present in this age group, such as dryness, cataract surgery, degeneration, etc. The most common indication that was present in this study was corneal ulceration of infective nature. This is similar to the studies obtained in other parts. However, there was a study in southern India which showed bullous keratopathy to be the most common cause. Studies in Brazil and developed nations have shown keratoconus to be the most common indication for keratoplasty. Pseudophakic bullous keratopathy was only 3.2% in our study. Other studies have shown a 27% of their cases. However, there were no cases of aphakic bullous keratopathy, which comes to show that there is an improvement in infrastructure, surgical techniques, and availability of trained surgeons, because the number of aphakic bullous keratopathy has drastically reduced, along with a reduction in intracapsular cataract surgeries. Fungal keratitis was the cause in 29 patients, which is about 31% of the cases. The high number of keratitis in our country can be due to the poor socioeconomic conditions, lack of personal hygiene, good health care, and access to primary healthcare facilities. This in turn emphasizes our need to increase the awareness about various ocular infections and their prevention to make primary eye care accessible to all. All the 93 surgeries performed were penetrating keratoplasties. This depends on the type of the disease that the patient has and also on the facilities and the training of the surgeons available.
1 minute more.
Yes, sir. In this case, the majority of the cases included full thickness corneal damage, and which could only be replaced by penetrating keratoplasties. However, there are some advantages of deep anterior lamellar keratoplasty over penetrating keratoplasty. From the study, we can see that the number of patients requiring keratoplasty was much higher than the surgeries done, which can only be increased by an increase in the strong campaign for eye donation and its awareness. The hospital cornea retrieval program is one such initiative which might serve the purpose. In conclusion, it can be seen that the hospital records are an important source of information, and corneal ulcer was the most common indication for keratoplasty from this study. These are the references, and I would like to thank Dr. Chandra Chakraborty ma'am for her guidance throughout the project. Thank you. Sir, you're not audible.
Then two.
Sorry, sir.
What? Any question? Professor Manisha Rathi.
Yes, sir. Very nice study, interesting and good picture.
Professor Pragati Garg, are you here?
Hello. Yes, yes, sir. Very nice.
Can you ask any question? You like to ask any question to Ms. Adrija on this particular presentation?
Dr. Ghosh, what were the number of cases you did in 2021? Penetrating keratoplasty cases. Did you see any case? Or did you come across any of these cases in the
No, ma'am. I was not able to find any cases. So I have tried a few times, but I could not find it. The timing was not right.
Why?
Sorry, ma'am?
Why did you not see any case?
Thank you.
I was not able to find the cases at that point. Whenever I went to the OT, there were other surgeries going on.
The answer is that during COVID, it was not done.
Thank you very much. Now we move on to all number 3 best candidate. Mr. Samar Thakkar. Mr. Samar is from Himachal Pradesh.
Samar Thakur.
Government Medical College, Noida. Mr. Samar, please start your presentation.
Yes, sir. Good afternoon, good evening, everyone. I'm Samar Thakur from Dr. RPGMC Tanda, and my topic is the case presentation of COVID-19 conjunctivitis. So here is the case. A 21-year-old boy presented to OPD with chief complaints of redness of eyes, foreign body sensation, ocular discomfort, joint pain, and fatigability. On ocular examination, he had bilateral conjunctival hyperemia, mild follicular reaction, and serous discharge, which was more in the left eye than the right eye. As you can see in the picture, here is a picture of the patient. Now, then he was diagnosed as a case of follicular conjunctivitis, for which he was treated conservatively with carboxymethylcellulose eye drops and cold compresses. On further evaluation, he was diagnosed with COVID-19 on RT-PCR done on a nasopharyngeal swab sample. After diagnosis of COVID-19, he was managed at home, after which he made full recovery without any complications. So now general introductory lines about COVID-19 conjunctivitis. COVID-19 can present with conjunctivitis, which usually occurs early in the disease. Amongst the past coronaviruses, there were no ocular disease or no ocular complications associated. COVID-19 conjunctivitis can occur as the first and the sole symptom without any systemic involvement. COVID-19 conjunctivitis by itself is not a very frequent symptom of the COVID-19 disease entity, but it is the most common ocular complication, and we can also say it is the only ocular presentation of COVID-19 conjunctivitis. Now, the etiopathogenesis. The risk factor for COVID-19 conjunctivitis is direct contact with a person having COVID. The transmission of COVID-19 conjunctivitis occurs through direct droplet inoculation on the conjunctiva and from the nasopharynx by reflux through the nasolacrimal duct. Now, for the entry into the cell, the virus uses ACE2 receptor on the conjunctiva, limbus, and cornea. Conjunctival specimens also express TMP-RSS2, which also aids in the entry of this virus into the cell, which is followed by viral replication, immunohyperactivity, and tissue destruction. The cell death results in the release of the virus into the tears. The virus-laden tears can go into the nasopharynx and therefore can result in the involvement of the lungs and therefore the systemic involvement of the patient. Now, The sustained replication in the conjunctiva, even after the recovery from COVID-19, is suggested by a case report of a patient with persistent positivity of the conjunctival swab despite nasopharyngeal tests remaining negative. Also, there was a case in which a SARS-CoV-2 RNA was isolated on a normal conjunctiva of COVID-19 patient without any ocular manifestations, which implies that the virus spreading by conjunctival contact can occur even in the patients without conjunctivitis. Such patients are asymptomatic for conjunctivitis, but still there is viral spread and transmission. Now the symptoms and signs. Since COVID-19 conjunctivitis is a viral etiological conjunctivitis, it simply presents as a conjunctivitis due to any viral etiology. The symptoms include the patient can be asymptomatic, the patient can have watering, patient can have foreign body sensation, patient can complain of red eye, patient can have mild photophobia. The signs of COVID-19 conjunctivitis includes the COVID-19 conjunctivitis begins as a unilateral redness of eye with follicular reaction, particularly in the inferior palpebral. Why inferior palpebral? Because the concentration of the ACE2 receptors on the conjunctiva, cornea, and the limbus is very less. And the virus is present in the dead cells, and dead cells get washed away with the tears into the inferior conjunctiva, and therefore the involvement of inferior palpebral conjunctiva is more. After the unilateral redness, the patient usually presents to the clinic when he has violated conjunctival hyperemia, which can be associated with chemosis, follicular reaction of the tarsal conjunctiva, epiphora, watery discharge, mild eyelid edema, and they can be associated with enlarged preauricular or submaxillary lymph nodes. Here you can see the patient, he has follicular conjunctival reaction in the upper and the lower fornices with serous secretion and mild chemosis. Diagnosis and management. For diagnosis, the sample we use to collect is the tear sample, which can be collected by Sherman strips or conjunctival swabs. We usually prefer conjunctival swabs. Although RT-PCR is a gold standard test for the diagnosis of COVID-19 disease entity, but it is a specific test, but very less sensitive in the diagnosis of COVID-19 conjunctivitis. It pertains to the fact that the concentration of the ACE2 receptors and concentration of the virus in the tears is comparatively very much lesser than the concentration of viruses in the sputum samples. So it is recommended that there should be 2 consecutive negative RT-PCR test results before a patient can be considered as a safe. Then management. The disease, the COVID-19 conjunctivitis is self-limiting disease, but we can manage it with conservatively with lubricants such as carboxymethyl cellulose eye drops and cold compresses. We can also prescribe prophylactic topical antibiotics for secondary bacterial infection. In some case studies, the patient shown improvement after the use of ganciclovir eye drops and acyclovir or valaciclovir eye drops. Now the
1 minute, please.
Yes, sir. COVID-19 conjunctivitis resolves itself without any morbidity if systemic complications do not occur. A meta-analysis concluded that conjunctivitis in the COVID-19 patients is usually associated with a more severe form of disease, both clinically and biochemically, and it usually had a worse outcome. Thank you.
Very nice, Dr. Samar Thakur. Nice presentation. I have a question for you.
Thank you, ma'am.
Can you please tell me what precautions should ophthalmologists take while seeing patients who is suspected to have COVID conjunctivitis?
The ophthalmologist can use face shields, and while examining the patient on slit lamp biomicroscopy, he can use slit lamp shields. Other precautions can be wearing mask all the time even by the patients and the attendants, the regular hand washing in uses of sanitizer, and the regular disinfection of instruments and surfaces having potential patient
I wanted
contact.
to know about the shields. That's very nice. You answered well. Any drops which can be used as a precautionary measure during the COVID season in the eye? If somebody you have in your family, can you suggest some drugs to that patient? Which eye drops?
Ma'am, for the COVID-19 virus, for viral conjunctivitis, you can prescribe acyclovir, valaciclovir eye drops or ganciclovir eye drops 3%. And ma'am, for bacterial superadded bacterial infection, we can prescribe moxifloxacin 0.5% eye drops.
Very nice. Good. Thank you so much. Nice presentation. Thank you so much.
Thank you, ma'am. Thank you very much.
Thank you very much. May we move on to hall number 3. We like to call upon the next speaker who has been selected based from hall number 4. Miss Niveda.
Yes, sir. Yes, sir.
She is from Kochi, Kerala. Amrita Institute of Medical Science with Niveda Sara Tenning. Yeah. Within 6 minutes, please.
Yes, sir. So, a warm good evening to respected judges on the dais and my fellow presenters. My name is Niveda Sara Tensing. I'm from 2018 MBBS batch of Amrita Institute of Medical Science and Research from Kochi, Kerala. And so today I'm going to talk about our a virtual reality based model of the eye, which we have developed at our Radion Institute. So technological advancements in the 21st century has always been a boon to our education. Recent expansions in and availability of software such as virtual reality, augmented reality, and 3D printing have led to its use in education. Traditional methods which are adopted by our medical colleges often do not provide students with a complete understanding of intricate structures such as the anatomy of the eye. The eye, as we all know, any eye or human eye is a very small and delicate structure. As a result, gross dissection does not provide students with proper understanding. And another reason is most of the colleges, just like mine, use bullseye for dissection. And virtual reality is something that allows a multi-sensory interaction with a virtual environment, which is created as a three-dimensional space by using AI and graphics, such as what you call VFX. And thus, it is an ideally suited tool for effective learning and understanding of tiny structures and intricate anatomy. And therefore, it helps us students to have a clear mental picture of these tiny structures. Hence, virtual reality can provide can impart a quality education. And in this presentation, as I said before, I will be discussing our indigenously developed anatomical model of the eye. And coming to making, so first we made this model in 3 steps. The first step is by making a 3-dimensional model, which was done using CAD software called Autodesk Inventor, where we made all parts of the eye separately. That is cornea, retina, everything we made separately, and then we combined it together to create the eye. That is a single file. And then our second step was rendering, where we give it a realistic appearance. That was done in a software called Blender. And then for making the video, the VR video, we use the software called Unity, which is a video gaming, virtual reality video gaming software. And as you can see, these are the 3 pictures. These pictures are the product of our model after the second phase, that is after rendering in Blender software. Now, moving on to anatomy and our virtual reality model, I would like to show you a video. As you can see, this is our video. And on one side, you can see the screen recording. And on the other side, you can see me moving and using the virtual reality Unity software. Here, you can see the extraocular muscles, the blood supply. You can see its insertion and all the vessels. You can see the eyeball, the cornea, the sclera. And now you can see me entering the eyeball. You can see all the external ocular muscles, the iris, the cornea. We have also shown all layers of the cornea. Here you can see the levels of the cornea, the anterior chamber, the iris. We have even shown trabecular meshwork. And you can see the zonules, the ciliary body, the lens, the oris areata. We can see the retina. We can also see the fundus with blood supply, retinal blood supply. We have the lens. again, we have the cornea and the trabecular meshwork. Here you can see the limbal palisades. Coming back to my presentation, sir. Now, our future plans. Our future plans. Our first future plan is to have test the effectiveness of the software-aided teaching compared to our traditional teaching methods, which are diagrams, flashcards, videos, and etc. And second is to make VR models for various pathologies such as diabetic retinopathy, corneal ulcer, cataract, retinal detachment, vitreous hemorrhage, etc. And also, it is our dream is to develop a virtual reality assisted surgical training. Yes, sir. My sincere gratitude to the mind behind this project, our HOD, Dr. Gopalas Pillai, Dr. Mahesh K, Dr. Yashovardhan Singh Sivaj for helping me throughout and guiding me throughout this project, and our technicians, Mr. Siren Xavier and Mr. Suji Chandru, without them, this project would have been not a reality, sir. Once again, thank you all.
Sir, it's very interesting. Nice presentation.
Thank you, ma'am.
Publish this anywhere, or is it available in the
No,
market?
ma'am. We are planning to publish it after conducting that is testing, ma'am. This is the phase 1 where we develop the software, and now it is phase 2 where we will collect this. We'll calculate a sample size and test it out on first year fresh students. That is a 2022 batch or 2021 batch, and then write an analysis and then abstract, ma'am.
Thank you. Very nice concept.
Thank you, ma'am.
Thank you.
Sir,
Thank
over to
you.
you.
Yeah. Now we will move on to hall number 5, Miss Nikita Vash. Miss Nikita Vash.
Yes, sir.
Yes, Miss Nikita Vash is from
Good evening, everyone. This is Nikita Vyas from Bharati Vidyapeeth Medical College and Hospital, Sangli. I am here to explain you my topic, ophthalmia and neonatal. So the introduction, ophthalmia and neonatal, also known as the neonatal conjunctivitis, it is defined as a mucoid, mucopurulent or purulent discharge from one or both eye in first month of the life, less than 28 days. The most common infection, it is the most common infection in neonates. Epidemiology, it represents the public health problem. The percentage of developing neonatal conjunctivitis is 2 to 12%. The risk factors are organisms present in the birth canal, premature rupture of membrane, prolonged labor, low level of immunoglobulins, trauma to the epithelial barrier, congenital nasolacrimal duct obstruction, indiscriminate prophylactic use of broad-spectrum antibiotics, premature infants, and infant in an NICU, so they may develop the infection. The causative organism most commonly is Trachomatis, Basidia gonorrhoeae, and the other bacteria are gram-positive and the gram-negative. So gram-positive are the Staphylococcus aureus, gram-negative E. coli, Klebsiella pneumonia, and the proteins discharge, which are the characteristic of the gonococcal infection. The incubation period for the gonococcal conjunctivitis is 3 to 5 days, chlamydial conjunctivitis 5 to 14 days, Staphylococcal aureus 2 to 5 days, Streptococcus pneumoniae, Haemophilus enterococci, it is 2 days, and Pseudomonas aeruginosa 5 to 18 days. History, so this might develop because of the institution of prophylactic chemicals. Symptoms of sexually transmitted infection. Conjunctivitis in close contact. The systemic illness such as pneumonitis, otitis and chlamydial infection, skin vesicle and the feature of encephalitis and herpes simplex. Prior watering without inflammation may indicate uncanalized nasal eclampsia. Then sign in the symptoms. The child is present with the pain in the neck, swollen, conjunctiva. It is hyper. There is a corneal involvement. It causes the punctate keratitis and herpes simplex virus. Then corneal ulcers occur because of the pseudomonas. Then nasal eclampsia duct. Other bacteria, it is 40 to 72 hours. Herpes simplex 5 to 7 days, and chlamydia infection more than 1 week.
I'm not able to get the audio. Is everyone able to hear?
Hello.
Hello. Yes, I can hear you now. Okay.
Sorry, ma'am. There was a network issue. That's why I'm so sorry.
No issues. No issues. Okay.
So there is a different type of the organism causing conjunctivitis, and they have a different time of the onset. This is a picture which is showing the sign and the symptoms of the eye, which is occurring because of the chlamydial infection. The investigation are the gram and the Jensen stain, bacterial culture, Papinicollis smear, nucleic acid amplification testing, viral culture, and immunofluorescence testing. So prophylaxis is single instillation of povidone and iodine 2.5%, erythromycin 5%, and tetracycline 1% ointment. Any suspicious vaginal discharge should be treated. Meticulous obstetric asepsis maintenance at birth. Newborn baby's closed eyelid should be thoroughly cleansed. If mother infected with the gonococca and the chlamydia, 1% tetracycline in the erythromycin eye ointment is used. The silver nitrate 1% solution, which is not used nowadays. The treatment for the chemical conjunctivitis, it is artificial tear. For mild conjunctivitis, it is topical antibiotic will give the chloramphenicol and fusidic acid. Then moderate to severe cases, if bacterial evidence on the gram stain, will give the topical antibiotic. And for the chlamydia infection, will give the oral erythromycin. Severe conjunctivitis, if there is gonococcal conjunctivitis, will give third generation cephalosporin. Herpes simplex infection will give IV acyclovir. This is a picture which is showing the eye affected with the herpes simplex virus and the eye after treatment for 1 week. The prevention programs, the screening for all the pregnant women for gonorrhea and the chlamydia infection, treatment and the follow-up of those found to be infected. Various program has been launched by the government. These are National Program for Control of Blindness, Vision 2020, the Right to Sight, Janni Shishu Suraksha Karyakram, Child Health Program, and the National Health Mission. Health Mission, the Women and the Child Health Program, and the National Sexual Transmitted Disease Control Program. Thank you. So I've done with my slides. Hello.
Time is over.
Sir?
Judges can ask questions.
Hello.
Yes, sir.
May I request the judges to ask the questions? 1 minute for each, 2 questions only.
If there is no question from the judges, can we move to the next presenter? Next presenter.
Last.
Dhanusri Matre. Dhanusri Matre is the next presenter.
Yes, ma'am. Yes, ma'am.
Dhanusri Matre is the next presenter.
Yes, ma'am. I'll share the screen.
Hello.
Yes,
Hello.
Yes, ma'am. Yes. Yes, ma'am. Hello. Hello.
Okay.
Ma'am, can you hear me? Hello. Ma'am. Can you hear me, ma'am? Okay. Good evening, everyone. I am Dhanashri. I am from Bharati Vidyapit Medical College and Hospital, Sangli. My topic is hypovitaminosis A, a nightmare for young eyes. So we know vitamin A is a fat-soluble vitamin, which is essential for night vision, maintaining normal glandular and epithelial function, normal body growth, offers good resistance to infection. Recommended daily allowance in adults is 800 to 1000 retinol equivalents. When the daily requirements are not met, it causes vitamin A deficiency, leading to nutritional blindness. VAD has been recognized as a major controllable health problem and a nutritional problem in India. Estimated 5.7% of children in India suffer from VAD. It occurs most frequently in the underprivileged young children and developed countries, commonly seen in infants with low birth weight. States badly affected are Andhra Pradesh, Tamil Nadu, Karnataka, Bihar, and West Bengal. So vitamin A has role in Wald's visual cycle, which is responsible for the normal vision. Risk factors for the vitamin A deficiency are living in an endemic area, low socioeconomic status, malnutrition, maternal malnutrition, zinc deficiency, coexisting measles or other respiratory or diarrheal illness. Etiopathogenesis, it can be either due to dietary deficiency of vitamin A, malabsorption from vitamin A, or reduced storage of vitamin A, like in liver diseases. Now, deficiency of vitamin A can either lead to systemic manifestation or ocular manifestation. Ocular manifestations of vitamin A deficiency is known as xerophthalmia, which affects conjunctiva, cornea, and occasionally retina. WHO classification of xerophthalmia includes XN, that is night blindness, X1A, conjunctival xerosis, X1B, bitot spots, X2, corneal xerosis, X3A, corneal ulceration, including less than 1/3 of cornea, X3B, corneal ulceration, including greater than 1/3 of cornea, XS, that is corneal scarring, XF is xerophthalmic fundus. Symptoms include night blindness, dryness of conjunctiva, liquefacted necrosis of cornea, and ulceration of cornea. Signs include first is conjunctival xerosis, wherein the conjunctiva becomes dry and non-wettable. Second is bitot spots. It is a triangular whitish spots in the interpalpebral area. Third is xerophthalmia, stage X2, corneal xerosis, where cornea becomes dry. Fourth is keratomalacia, including less than 1/3 of corneal surface, which includes corneal ulceration due to liquefactive necrosis. Next is keratomalacia, including greater than 1/3 of corneal surfaces. Next is corneal scars, which leads to opacity. And last is ophthalmic fundus, which leads to raised whitish margins on the fundus. Investigations include clinically assessed eye signs, biochemically determined concentration of retinol in serum and plasma. Differential diagnosis includes trachoma, dry eye, retinitis pigmentosa, and pingocula or pterygium. Treatment and prophylaxis. So prophylaxis, according to National Immunization Schedule, first dose of vitamin A should be given at 9 months, that is 1 lakh international unit. Second dose, that is of 2 lakh international unit at 16 months, and then one dose every 6 months till 5 years of age. Treatment of vitamin A deficiency, that is immediately upon diagnosis, we should give 2 lakh international units orally. Next day, 2 lakh international units orally, or within 1 or 4 weeks, 2 lakh international units orally. Other consideration we can consider, that is children between 6 to 11 months of age or less than 8 kgs should receive half the dose, that is 1 lakh international unit. Intramuscular injection of water miscible retinal palmitate are given in children with severe stomatitis who cannot swallow or with persistent vomiting. Now, control and prevention. Now we know that vitamin A deficiency is preventable and curable. So we give a primary eye care, which can be treated and prevented at grassroots level by locally trained primary healthcare workers who are first to make contact with the community. Their activities include health education, dietary advice, immunization, better hygiene, and sanitation. There are three main intervention strategies through which we can control this vitamin A deficiency. That is short-term approach, medium-term approach, and long-term approach. Short-term approach, we can give prophylactic administration of vitamin A in the endemic areas. 1 lakh international unit for less than 1 years of infants and weighing less than 8 kgs. 2 lakh international units for 1 to 6 years of children orally every 6 months, and 20,000 international units for pregnant and lactating mothers. Medium-term approach includes food fortification with vitamin A like dalda and milk, and long-term approach includes promotion of adequate intake of food rich in vitamin A such as eggs, carrots, broccoli, papaya, fish, likewise. Now, related national programs which can aid are vitamin A prophylaxis program Vision 2020, National Program for Control of Blindness and Visual Impairment. So now the conclusion. Like
1
we
minute
know
more.
that okay, ma'am. Vitamin A is a very major cause of blindness in India, but it can be prevented by a very primary healthcare workers, or we called it as barefoot doctors, who can help us in creating awareness, immunization, dietary advice, and awareness about health and sanitation. Thank you. Ma'am, I'm done with my slides.
Any question from the judges? Any question from the judges?
स्टार्ट होगा इजी से स्ट्रेस है सब हॉल ए सब हॉल खोल दो ए डॉक्टर प्रीतम हॉल खोलो सब हॉल खोल देते हैं ये सब
Hello. Hello. So can we end?
पहुंच गया, खुल दिया ना, ठीक है। ये तो डॉक्टर का काल क्या, वो तो निवेदा अभी भी है, ये रखी हुआ है। हेलो हेलो हेलो, कौन है? रिसीव नहीं करता है अभी, है? हेलो डॉक्टर दीपक मिश्रा, हेलो। ये हमारे मोटा दिन तो चलता नहीं, तो आगे खोलो, सबको हॉल खोलो ना। हाँ, गुड इवनिंग डॉक्टर दीपक मिश्र। এই আমাকে দিন তোটা ওই কাগজটা দেন, ওটা নিয়ে ভুলে যাবো, ওই কাগজ রেখে। হ্যালো, গুড ইভিনিং ডক্টর দীপক মিশ্র। The whole one, এইটা one. This is absent. This is absent. কোথায় স্টার্টেড?
ওইখানে করছে ওরা।
কোথায় হচ্ছে?
ওরা করছে, আপনি দুতে যান, পরেরটা যান।
এইখানে হল 2 খুলবো?
হ্যাঁ।
তাহলে এটাকে হল 2 খুলতে হবে। হল 1 ওইখানে আছে? কেউ আছে ওখানে?
हॉल 1 में कोई है इधर नहीं?
इधर हॉल 2 खोलो तो। ये जानता नहीं, इसको सिखा दो, इसको सिखा दो। हेलो, ये हॉल 2 आप सब नहीं पाए ना, उनको पूछो कि मैं नहीं जानता हूँ, मुझे सिखा दो, नहीं तो क्या कर पाए। ये हॉल 2 इसका आइडिया और ये है। हॉल 2 इधर लो, इधर आइडिया है। हॉल 1 में कोई आया? कोई लोग आया उधर पे?
नेटवर्क नहीं आ रहा है।
इधर नेटवर्क इशू है ना। इधर हॉल 2 खोलो। एक हॉल 2 करो, एक हॉल 3 करो, एक हॉल 4 करो, हॉल 5, हॉल 6।
नहीं दे रहा कनेक्शन।
वो कौन नहीं कर?
नीचे से कनेक्टिविटी के लिए फोन करना पड़ेगा। वी नीड गुड कनेक्शन।
हॉल 2 में कोई नहीं आया सर
अभी कोई हॉल में नहीं आया?
2 में नहीं आया।
2 में नहीं आया।
Who is the judge in 2?
देखता हूँ।
डॉक्टर नेहा सर वर्मा आ गए। डॉक्टर नेहा वर्मा मैम अभी ज्वाइन की।
बना दिया ना, ठीक है।
अभी ज्वाइन हो रहा है।
शुरू करना पड़ेगा। जज कौन बोला? 2 में? में जज कौन?
इसमें कौन सा चल रहा है? 1 चल रहा है क्या? 1
में जज
One का जज। हेलो संजीव भाई, कहाँ है? 10 मिनट्स में ज्वाइन करेंगे। बोलो वेबिनार में 10 मिनट्स पे ज्वाइन करने के लिए, ठीक है? वो व्हाट्सएप मैसेज भेज दिया। हाँ, अरे डिस्कनेक्ट हो गया, नेट नहीं लगता है इधर पे, पागल कर देते हैं। সুচিতা পারিজাকে পাওয়া গেছে। ভালো করেছে, কারণ সুচিতা পারিজাকে জয়েন করে
রেখেছেন, আমি কিছু বুঝছিলাম তখন থেকে বলে যাচ্ছি যে আমাকে দিন কিছুতেই।
আপনি এখন নিন না, কালকের জন্য পুরো করুন, এখন করুন কালকের জন্য।
আপনি বললেন আমার সব ঠিক আছে, তারা থাকবে, এখন এই স্ক্রিম করলে হয় কখনো? হল 2 তে কি আছে, দীপক মিশ্র করবে কি করবে না?
দীপক মিশ্র হল 2 তে সঞ্জীব মিত্তাল আসছে, এখন
মিত্তালের দেরি হবে, ঠিক আছে চলো হল 3।
হল 3 তো মনীষা রতি। আপনাকে তো টেলিফোন নাম্বার দিয়েছে, সেগুলো বের করে লিখুন না ভাই, তাহলে আপনাদের।
না সেটা কোনো কথা না, আমি অনেক আগে থেকে আপনাকে বলেছি এটা করবো, যে আমি আমাকে দিন আমি করছি, আপনি বলছেন না পরে হবে।
স্যার এখন লিংক চাই, এখন ওই লিংক এখন পাঠাই কি করে? আমাকে লিংকটা দিতে পারে? সব লিংক চাইছে, কেউ কিছু খুঁজে দেখে না, লিংক সব ভেজো তো। अरे वो लिंक सब भेजो तो, लिंक सब भेजो तो, लिंक भेजो तो, लिंक भेजो तो, वो पूरा लिंक भेजा ना, वो लिंक कहाँ भेजो तो, हैं भेजो तो, वो जांच में भेजो तो, कि कहाँ पे भेजो, जांच में भेजो, वर्चुअल जांच में भेजो तो।
फोन नंबर सर का फोन बोलो सर। हॉल नंबर 3 में आप प्लीज आ जाइए, प्लीज। हॉल नंबर 3 में कौन खुला है? 4 नहीं खुल रहा है, 4 में कौन है? हॉल 4 में,
हॉल 4 में क्या है दिखाओ, लिस्ट दिखाओ ना, हॉल 4 में क्या चीज है, स्टार्टिंग हो।
तो कौन है यहाँ पे?
हॉल 4 में तो
अब तो बोला सब रेडी है, सब रेडी है,
भेज दिया भाई, अब फील बचता है।
प्रेजेंटर देखे ना, जो प्रेजेंटर আছে কিনা।
हेलो
हेलो डॉक्टर रति, प्रोफेसर मनीषा।
No, I think they left. Is this hall number 1?
Yes, डॉक्टर साथी मजुमदार। अच्छा देखो ना, आपने सुना?
Yes, but हाँ चंदनदी,
हाँ, this is hall number 1.
Chandranadi asked me to join hall number 1.
Hall number 1, I'm telling. Hall number 1, this is on thesis abstract for the PGT.
Okay.
Thesis abstract PGT. Okay.
Okay, fine.
Okay.
What should be the distribution of marks?
And same. And
okay, same.
Pragati Garg is also.
Yes, sir. I'm here, sir. You've asked me to join hall number 1.
Yes, in hall number 1, Dr. Niveda, why are you here? Dr. Niveda Sara, this is for the PGT session. You please leave. This is PGT. Niveda Sara, this is not your hall. So this is the hall for the PGT session. Hall number 1 on thesis abstract. Okay. Can you hear to me?
उनका तो 3 है,
3, उनका हॉल 3। हेलो हेलो हेलो, नहीं आता है, इसको नहीं सुनाई जाते हैं। कोई नहीं।
मनीषा मैम को बताना पड़ेगा।
ये हॉल
ठीक है,
होगा,
हो जाएगा। बोलो ठीक से, पासवर्ड ठीक से बोलो। 5 और 6 में किसको देना है? 5
देखो ना, मैं तो जल्दी खा।
Hello, is there any PGT in
Hello,
this hall?
can you hear to me?
Is there any PGT in this hall?
This is hall
Yes.
1 on thesis abstract for the postgraduates. I would request the undergraduates to leave this. I would request the undergraduate to leave this hall. Tripura Sundari, please leave this hall. Only the postgraduates should be there. Only the postgraduates should be there. Only the postgraduates. Dr. Swati Majumdar is here.
Yes, yes, sir.
Yes.
I'm here.
Dr. Preeti Garg is here. Professor Preeti Garg.
Pragati Garg, sir. Yes, I'm here.
Pragati Garg is here, madam.
Yes, sir. Yes, sir.
Thank you, madam. So you please proceed and start the session to judge the thesis abstract. Thesis abstract, and in this 6 minutes presentation with questions, and select the best one. This is the first round. And in this session, we have got 5 presentations. In each session, small sessions, 5 presentations each. 5 presentations each. Is there Goriosi Lakhar? Goriosi Lakhar is here. Lita Kuli is here. Souvik Bodua is here. Souvik Bodua. Goriosri Lakhar, Souvik Bodua. Alankrita Hajarika is here.
Yes, sir.
Priti Rekha Das is here. Priti Rekha Das. Najma Begum is here. Najma Begum. Who else are there in this hall? Who else are there?
Myself,
Asim Kumar is here.
Sister.
Asim Kumar is here.
Yes, sir.
Asim Kumar is here.
Yes, sir.
Yes. এই কলম কোথায় গেল? একটু দাঁড়ান। Asim Kumar is here. Okay, all right. And some Dr. Nokul is here.
Yes, sir.
Nokul is here.
Yes, sir.
Yes. So there are 4 candidates in this session. So please be kind to start. Dr. Sahana Said. You are from Hyderabad. You are here.
Yes, sir.
So was it your scheduled? You are on thesis abstract. You are on thesis abstract.
Yes, sir.
Thesis abstract. Yes. So carry on. So start. Professor Preeti Garg and Dr. Start.
Okay, who is the first speaker?
So once again, I like to make the repetition. Dr. Goriosri Lakhar is not there. Goriosri is not there.
Dadra, kindly start it.
Priti Rekha Das.
Yes, sir.
Priti Rekha Das is here.
Yes, sir.
Das is here.
Yes.
Yes.
Yes, sir.
Then Dr. Najma Begum is here. Najma Begum. Then Dr. Asim Kumar is here.
Yes, sir.
Yes. And then who else? Who else is there? Dr. Nokul and Dr. Sadia. Sadia is here? No. Who else is there other than Dr. Nokul? Who else? Who else? Dr. Nokul, from which medical college you are?
Sir, RPGMC Tanda, Himachal Pradesh.
Tanda, yes. And who else is there?
Sir, I am Dr. Kamlesh from Bharati Vidyapit Sangli.
Dr. Sapnesh from Bharati. You are scheduled here?
Sir, Dr. Kamlesh. Actually, my
Kamlesh, you are
slot is
scheduled. You are scheduled here.
yes, sir, in thesis abstract only, sir. But my timing is 8:15 to 9 session.
Okay, Dr. Sahana from Sarojini Devi Eye
Yes, sir,
Hospital.
from Hyderabad.
Okay.
Yes, sir.
So you please start your presentation, and one best presentation will be taken up. Okay, carry on.
Okay, who is starting first? Sahana Sayed?
Yes, sir. Yes, ma'am.
Okay, you can start with your presentation.
Ma'am, should I just read out my presentation or should I share my screen?
You should share your screen.
1 second, ma'am.
Please start in the hall. Please start. Dr.
Hello.
Shati.
Hello.
Hello.
She's going to start. She is going to start.
Okay, start.
Ma'am, but I'm not able to share my screen.
So another speaker?
Another speaker who is ready? Who else is there for the thesis abstract? Dr. Nakul?
Dr.
Yes, ma'am.
You're ready, you can start with the presentation.
5 to 6 candidates, 6 minutes each. 6 minutes each. You can ask questions, and the best one will be selected amongst 5 or 6 candidates. Dr. Nijapuli is here. Dr. Suchita Singh.
To ask the
Dr. Adoni Agarwal. Adoni Agarwal is here.
আরে পর তুই কি খুলে রেখেছিস শুরু থেকে হ্যাঁ পর
is here.
Hello.
Hello, Swati, we can't see your screen.
Dr. Nakul, who is going to present? Doctor.
Yes, ma'am. Should I present?
Yeah, you can start.
But she's already presenting, ma'am.
Okay, let her present then. Now we can see your screen. Ma'am, can you see pediatric traumatic cataract screen?
Yes.
Yeah.
You are visible.
Okay, ma'am. Okay, I'll continue then. Hello. You can start. I'll continue, ma'am. Yes, ma'am. I'm Dr. Sahana V. Honderli. I'm a second year postgraduate from Sarojini Devi Eye Hospital, Gandhi Medical College, Hyderabad. My topic is study on surgical modalities in the management of pediatric traumatic cataract. Self-declarations: there is no financial interest. Informed consent obtained from parents of the participating children, and ethical clearance is obtained. Introduction. Pediatric traumatic cataract is one of the leading causes of monocular blindness in children, accounting for 29 to 57% of pediatric cataract cases. So issues in the pediatric age group like decreased scleral rigidity, increased vitreous upthrust, unstable anterior chamber, increased elasticity of anterior capsule, and higher tendency of post-operative inflammation, makes surgical manipulation in them more complex and important than in adults. Without effective and prompt treatment, pediatric cataract will deteriorate vision, including loss of binocular vision and even amblyopia. So that's why cataract in children is important to manage as soon as possible. Purpose of the study is to analyze various surgical options available and suitability of each in pediatric traumatic cataract cases. Materials and methods. A hospital-based prospective observational study of 37 children between the age group of 2 to 16 years undergoing unilateral ocular surgery for traumatic cataract was conducted. Inclusion criteria were patients in the pediatric age group with prior history of trauma to cataractous eye, and exclusion criteria included congenital cataracts, developmental cataracts, and other complicated cataracts. This is the methodology I followed. Detailed history taking was done to determine the cause of trauma and associated symptoms. General physical examination was done. Best corrected visual acuity was tested. Slit lamp examination was done. IOP measurement using non-contact tonometer was done. Roplas was done to check for patterns of lacrimal apparatus. B-scan ultrasonography was done. Keratometry and A-scan to determine IOL power, and then pre-anesthetic evaluation was done. These are the results of my thesis. 25 out of 37 cases could be easily managed with cataract removal by various modalities and primary IOL placement in the bag, which included 11 lens matter aspirations with foldable IOL, 7 phacoemulsifications with foldable IOL, 4 small incision cataract surgeries with posterior chamber IOLs, and 3 lens matter aspirations with foldable IOLs placed in the sulcus. 8 cases showed poor PC support, and hence lens matter aspiration or lens extraction was done, and then the patient left aphakic and called for secondary IOL placement on a later date. Then 4 cases were posted for secondary IOL placement, and 1 among them was scleral fixated IOL placement. 8 cases had associations like corneal tear, angle recession, adherent glaucoma, and retinal detachment. In 4 cases, cataract extraction and IOL placement was done after prior corneal wound repair. And in other cases, membranectomy and synucleolysis was also done during cataract surgery. 8 cases required anterior vitrectomy. The same thing has been shown here in the form of a pie chart. 67.56% of the cases were managed easily with cataract extraction and IOL placement in the bag. 21.62% cases were managed by lens matter aspiration or lens extraction, and patients were left aphakic. 10.81% of the patients were posted for secondary IOL placement. These are the various modalities employed in cataract extraction and primary IOL placement in the bag. Various modalities, maximum 44% of them were lens matter aspiration with foldable IOL in the bag. 28% were phacoemulsification with foldable IOL in the bag. 16% were SICS with PCIOL, and the remaining 12% were lens matter aspiration with foldable IOL in the sulcus. These are the pre, intra, and post-operative pictures of traumatic cataract where phaco and foldable IOL in the bag was placed. Pre-operative, intraoperative, and post-operative picture. This is the pre-operative picture. Pre-operative picture of traumatic cataract with posterior synechiae. This is post-operative picture of traumatic cataract with angle recession, post-synechiolisis, and anterior vitrectomy. This is post-operative picture of traumatic cataract with corneal wound. This is the intraoperative and post-operative picture of scleral fixated IOL placement. Discussion. Propensity for increased post-operative inflammation and capsular opacification, and a refractive stage that is constantly in a state of flux due to growth of the eye, and there is difficulty in documenting anatomic and refractive changes due to poor compliance and a tendency to develop amblyopia, makes management of cataract more, that to traumatic cataract in children difficult and different from adults. So this study helped in deriving conclusions regarding various surgical modalities in management of traumatic cataract in children, and hence give them a better quality of life. My conclusion is a good number of children were served justice by in-time management of one of the leading causes of monocular blindness, that is traumatic cataract, with an open approach to different surgical options available in tertiary care center, that is our hospital, and hence given better vision and prevented development of amblyopia. These are my references. Thank you.
Okay, thank you, Dr. Sahana. This was a thesis topic.
Yes, ma'am.
I just wanted to ask how you have uh, selected the patients that these traumatic cases should be operated by FACO or by SICS, and whether the primary lens implantation is to be done or secondary lens implantation is to be done. How have you divided the patients into these categories?
Ma'am, actually, this is one surgeon based study, ma'am.
Okay.
On table, my guide used to decide like actually we wanted to do phaco for all the cases where only small incision would do, but in few cases where we could not do because of other associated complications, they were converted into SICS. And if there was any PC rent noted, then patients were left aphakic and called for secondary IOL placement.
Okay. So these modalities, everybody know. What was the novelty in your thesis topic? What conclusions you were able to draw that which surgery is better? Have you compared them?
Actually, post-operative comparison is not there, ma'am. It is just that like what are the various modalities available and how can we easily tackle as many cases as possible in the first setting itself. And with the other, maximum we did was phacoemulsification with foldable IOL in the bag.
Okay, whatever. What was the visual prognosis, comparative visual prognosis in all of them? Immediate post-operative.
My study is only up till the surgical modality, ma'am. Post-op vision is not included in this. So,
okay.
Okay, Dr.
Yes,
Shahana.
Yes,
Dr.
ma'am.
Shahana, I have one question. When you are taking decision, how do you select your case for opting posterior capsular axis and anti-vitrectomy? Did you do in all the cases PCC and vitrectomy, or you just did the phacoemulsification or SICS and keep them aphakic or pseudophakic, whatever it is? Because PCO is in case of
Yes,
pediatric
ma'am.
cataract is the rehabilitation which matters more,
Yes, ma'am.
isn't it? So how did you do this surgical approaches actually, with
Ma'am,
or without?
It was done with the posterior capsular axis, ma'am. Yeah, almost all cases there was posterior capsular axis was done, ma'am.
Okay. Okay, so what could be the complication following this pediatric cataract surgery? I mean, we have to follow it up for 3 to 4 years or more, and you should look for
Yes,
the changes and the intraocular pressure. So, what is the risk factor? If everything is
Pediatric
okay, patient
patients
is
are
not
more
amblyoptic, but
immediate post-op pediatric patients are more prone for developing more inflammatory reaction, ma'am. So
and long term,
frequent
long term, you have to screen for
long-term
glaucoma
refractive.
also. Glaucoma
Yes,
also.
ma'am. Okay. Yes, ma'am. Okay.
Okay.
Okay, thank you, Sahana. Now we'll have the next
Thank you,
speaker. Who is there, Dr. Nazma?
Oh, yes, ma'am.
Okay, you are ready?
Yes, ma'am. Yes, ma'am.
Okay, start with the topic.
इसका bed number 14 का
Ma'am, is my screen
morning
visible?
hemoglobin कितना था?
No, the screen is not visible to us.
नहीं अभी देखो
Ma'am, I'm not getting option to share the slide.
Contact the support group.
Okay, ma'am.
I request the support group, the host, to kindly help her in sharing her screen. Okay, now it's visible.
Okay. Good evening, everyone. My topic of presentation is a clinical microbiological profile of fungal corneal ulcer. Okay. Fungal corneal ulcer is the most common infectious disease that is potentially sight-threatening ocular condition in clinical practice. There are patterns depending on different patient, depending on the patient population, occupational risk factors, and climate. Filamentous fungi are responsible for a large proportion of these corneal infections in tropical climates. Then temperate climate, particularly following trauma with vegetative material. At least 70 genera of fungi has been associated with fungal keratitis. Of these, Fusarium species and Aspergillus species are responsible for 70% of cases. Aims and objectives were to find out the proportion of fungal corneal ulcer among infective corneal ulcer patients to the patient department of
Hello.
Ophthalmology.
Hello.
Nazma, we can't hear you.
College. And to find out
Hello. Your
etiology
audio is not working, Dr.
and
Nazma.
clinical presentation of fungal corneal ulcer, and to find out the type of fungus causing fungal corneal ulcers, and also to study the outcome following management of fungal corneal ulcer. Materials and methods are placed. Yes, ma'am. Hello.
Hello. Hello. Hello. Hello, Dr. Najma. Your screen is not visible and your audio is also having some problems.
Hello, ma'am.
Hello, Dr. Najma.
Hello.
You are
Ma'am.
not
Hello.
audible, and your screen also is causing some problems. Not visible. I guess.
Yes, ma'am. I can hear you, ma'am.
Yes, but
Hello, ma'am.
sound is
Can you hear me
breaking.
now? Hello. Yes, ma'am. Yes, ma'am. I can hear you, ma'am.
Then
Yes,
continue
ma'am.
because it was causing some problem.
Hello, ma'am. I can hear you clearly.
Okay.
Ma'am, I can hear you clearly.
Okay,
Ma'am, can I
then.
continue?
Move on.
Okay. The place of the study is a Silchar Medical College and Hospital, and duration was 1 year from June 2020 to May 2021. And it is a hospital-based prospective study. The sample size were a total of 104 patients of infective corneal ulcer attending the outpatient department and emergency department of Silchar Medical College and Hospital were selected. The inclusion criteria were a patient with infective corneal ulcer more than 12 years of age attending outpatient department and emergency department. The exclusion criteria were acanthamoeba keratitis, then non-healing ulcer, peripheral ulcerative keratitis, and ulcer associated with autoimmune conditions, and patients presenting with complications of corneal ulcer like perforation of corneal ulcer, corneal opacity, or adherent leukemia or anterior staphylomas, etc. Patient with history of and also patient with history of steroid treated keratitis were not selected for the study, and also who were non-compliant and did not give consent, and patient with diabetes mellitus. These are excluded from the study. Then my results were I got mycotic keratitis of 38.46% and other keratitis of 61.53%. And the age distribution in our study was 51 to 60 years age group has the most number of patients, like 13 cases we got in this age group. Following the 8 cases of 41 to 50 years age group. The sex distribution, the male were outnumbered the female, like in 57.5% cases were positive in male, and then 42.5% were cases were female patients. Regarding occupation, the most number of cases were found in farmer, the patient who are farmer by occupation, which were 18 cases, followed by tea garden laborer, followed 9 cases, and then distribution of mycotic keratitis in relation to trauma. Paddy leaf, uh, that paddy injury by paddy leaf, we got total 9 cases, and with tea leaves, injury by tea leaves, we got total 8 cases. The growth pattern, we found 56 cases of pure bacterial growth, and then 37 cases of pure fungal growth. Then 8 cases we got negative culture, and 3 cases we got mixed growth, like fungal plus bacterial. The fungal spectrum where most cases we got positive for Fusarium solani, which was 32.5%, following which Aspergillus fumigatus, which was found to be positive for 17.5% cases. And the outcome following treatment were mostly the corneal opacity with variable vision. The discussion is, in this study, Fusarium solani has the most number of positive cases, which is 32.5%, and the patient number was 13, which is followed by 17.5% cases of Aspergillus fumigatus. The fungi are identified by colony characteristic, arrangement of spores and mycelium, and are confirmed by studying microcultures. Distribution of different species of fungi in this study was similar to the study done by other, like Chandar et al. And Irimanath et al., Upadhyay P. et al., Mohandas T. et al. Conclusion of my study is fungal corneal ulcer continues to be an important cause of ocular morbidity, mostly in males inhabiting rural area and involved in outdoor agricultural activities. Various factors are involved, such as trauma and the injudicious use of topical antibiotics and steroids. If strong clinical suspicion of fungal keratitis exists, KOH mount and gram staining are useful in diagnosis in resource-poor setting. The definitive diagnosis can only be achieved by microbiological evaluation. Then Fusarium solani and Aspergillus are the most common species isolated from fungal keratitis. Accurate diagnostic tests not only play a key role in the patient management, but also reduce the risk of the patient developing long-term complications like corneal perforation, staphyloma, etc. My references, these are my references. Thank you.
Dr. Nazma, thank you for the nice presentation. I just want to ask you about, you have not mentioned what investigations you went through to reach to a specific diagnosis. What have you done in your thesis?
Okay, ma'am. I sent corneal scraping, and also the most important thing was KOH mount and culture characteristic in the plate. Plate. Hello, ma'am.
I can't
Hello,
hear
ma'am.
you.
Can you hear me?
No,
ma'am, culture, ma'am, culture. KOH mount and culture characteristic of SDA agar plate, ma'am.
Okay.
Culture characteristic, ma'am.
Okay, fine.
Culture plate.
One more question by me. You have
Okay, ma'am.
You have excluded non-healing corneal ulcers. How you have judged that this is a case of non-healing corneal ulcers? What are the criteria for that?
Okay, ma'am. The non-healing ulcers are the patient present, those patients who presented with corneal ulcer with previous use of other medication, local medication and other medication, and also after previous history of other medication, and also long-term corneal ulcer which was not responding to treatment. Those cases, ma'am.
Okay. Dr. Mazumdar, you want to ask some question?
I have only one question. Do you have any message, I mean new message in preventing this fungal corneal ulcer to the community? Do you think your study will help?
Yes, ma'am. The message is,
Was
now
there any difference?
previously it was
Your locality
previously
and the results from other geographic areas within India?
Yes, ma'am. Previously it was found to be, and I got Fusarium solani is the most common species. Means in most cases were positive for Fusarium solani. But there were lots of studies done previously. They used to get Aspergillus fumigatus. So there is a shift from Aspergillus fumigatus towards Fusarium solani in this area.
What could be the cause? Do you have any idea, or do you want to research on?
Maybe, ma'am, due to poor hygiene, ma'am, and also the change in the environmental condition.
Okay. Your study included the COVID era, no?
Yes, ma'am.
COVID pandemic.
Yes, ma'am.
Okay, thank you. Dr.
Thank you, ma'am.
Thank you, Nazma.
Thank you so much, ma'am.
We'll shift to our next speaker. Who is there? Alankrita?
Yes, ma'am.
You're ready?
Yes, ma'am.
Okay. We can continue with your presentation.
Yes. Ma'am, is my screen visible? Ma'am, is my screen visible?
Yes, it is.
I'm trying to do full screen. Warm greetings to all the judges, organizers, and fellow presenters in Fopi. Myself, Dr. Alankrita Hazarika, a postgraduate trainee from Assam Medical College and Hospital. My thesis abstract is on ocular adnexal and anterior segment complications in patients undergoing radiotherapy for head and neck cancer. So, starting with the introduction, radiotherapy is the treatment of choice in patients with low-grade ocular adnexal tumor and other head and neck cancer. It offers an alternative to enucleation for patients with intraocular tumors but may end up with a myriad of other ocular complications, as seen in figure 1 and 2. Radiation-induced ocular morbidity encompasses a spectrum from transient eyelid erythema to complete loss of vision. It has been reported that anterior segment complications affects up to 23% of patients receiving radiotherapy. The aim of my study is to observe the various ocular adnexal and anterior segment complications in patients undergoing radiotherapy for head and neck cancer. And my objective is to evaluate the type of complications. So my study was a hospital with prospective study consisting of 85 patients undergoing radiotherapy for head and neck cancer, attending the Department of Ophthalmology and Radiation Oncology, ANCH Dibrugarh, from July 2020 to June 2021. The inclusion criteria includes all the patients diagnosed with head and neck tumors undergoing radiotherapy and patients of all age group, whereas the exclusion criteria are patients receiving simultaneous chemotherapy, cases with known pre-existing ocular disease, patients with systemic diseases, autoimmune diseases, and blood discrepancies. All these patients underwent complete ophthalmic evaluation, including detailed history. Base-corrected visual acuity was noted, Schimmer's test was done, dioptrin breakup time was tested, slit lamp and fundus examination were there, and these patients underwent periodic follow-up throughout the period of the study. So data was collected and tabulated in Microsoft Excel and was summarized in proportions and percentage as per the statistical product and service solutions 20.0 software. These are the results and observations of my studies. The dry eye constitute the highest number of anterior segment complication, consisting of 16.47% of the total cases, followed by erythema, meibomitis, madarosis, dermatitis, cataract, conjunctivitis, and lastly a single case of punctal stenosis. And this is a graphical representation of all the ocular adnexal and anterior segment complications found in the studies. Now coming to the discussion part, Lena et al. In 2004 reported that 76.5% of the patients receiving radiotherapy for tumor of head and neck experience ocular side effect, which is high compared to that of ours, which is 45.84%. In 2012, Vandere et al. Mentioned in their article that the incidence of dry eye syndrome rises steadily from 6% at 35.39 grays to 50% at 45.49 grays. Maharia et al. In 2019 mentioned in their study that erythema was noted in 5% of the total cases, and it's more when the radiation was increased to 20 to 30 grays. The same study also found that 2.56% of the total cases had cataract. Nuzi et al. Described an overall incidence of 16% of eyelid complications. Jagannathan et al. Showed the onset of madarosis only for doses greater than that of the 40 grays. In this context, I would like to mention that in our study, radiation dose range mostly from 40 to 60 grays. Metler and Upton in their study mentioned that the initial skin reaction started after 2 weeks, and that when external beam radiation therapy was used. Another study done by D. Chen et al. In 2018 showed diffuse meibomian gland loss in both the eyes, disease eyes 12 months after the onset of radiotherapy was started. Now coming to the conclusion part, in our study, 45.84% of the patients underwent radiation treatment for head and neck cancer, and among which dry eye is the most common complication, accounting for 16.47%, followed by erythema 9.41%, meibomitis 5.89%, madarosis, dermatitis, and cataract, each consisting of 3.53%, and lastly conjunctivitis and punctal stenosis. Ocular complication in patients radiated for head and neck cancer is unavoidable, but this complication can be minimized or delayed using modern radiation technique and with proper protective measures. So the take-home or the key message is thorough clinical evaluation leads to early detection of these adverse side effects, and the timely and specific treatment will restore vision, thus preventing the normal ocular function and ensuring better quality of life. Lastly, I would like to conclude my presentation with the photographs of these patients showing in figure 5. Figure 5, it shows a patient of basal cell carcinoma receiving radiotherapy, and presented with madarosis. In figure 6 shows a patient of sebaceous cyst carcinoma presented with conjunctivitis after 3 doses of radiation therapy. In figure 7, there is the case of post-radiated case of adenocystic carcinoma presented with dermatitis. And lastly, in figure 8, we see a case of erythema in a patient radiated for maxillary sinusitis. Maxillary carcinoma. These are my references, and thank you for your patient listening.
Okay, thank you, Dr. Alankrita.
Thank you, ma'am.
I wanted to ask, you said dry eye was the commonest complication after radiotherapy. I agree with that. But
yes, ma'am.
Have you looked for the prevalence of dry eye before radiotherapy and compare the two values?
So, ma'am, as per the literature, the dry eye cases that are found in my cases are very low compared to all the literatures that are there.
But still, that is the commonest complication of all the complications you have faced.
Yes, ma'am.
Okay.
Yes, ma'am.
I want to ask whether this dry eye was pre-radiotherapy also this might be pre-existing before radiotherapy. Have you looked for the dry eye before starting with the radiotherapy?
Yes, ma'am. Yes, ma'am. That has been looked for. Actually, I did on-site shimmer tests, and those two patients who can come to our department, tear frame breakup time was done. So only these two tests were done to detect dry eye in the case in all the patients.
Okay. So you have excluded those cases which had these complications beforehand?
Yes, ma'am. Yes, ma'am.
Okay,
ma'am, actually, all my cases are such type of cases that have like radiotherapy was started from the starting of my treatment process only. I didn't include any cases for like where radiotherapy was given previously before starting my study.
Okay, so that means that shows that again brings to my question that you have not assessed the pre-radiotherapy problems which a patient might be having in the eye. So you have
yes,
not assessed them. Okay.
No, ma'am. The cases that 85 cases, all the cases before starting the starting of my study, shimmer stays and tear frame breakup time were done, ma'am.
Okay, fine. Dr. Majumdar, I have no other question.
No, ma'am. I don't have any question.
Okay. Thank you, Dr. Alankrita.
Thank you, ma'am.
Okay. Next speaker, Dr. Nakul.
Yes, ma'am.
Okay,
I'm
you
ready.
can start.
Ma'am, is my presentation visible? Hello.
Hello. We can see that. Okay.
Good evening, everyone. The topic for my presentation the topic for my presentation is clinical profile of patients with optic atrophy. Optic atrophy refers to the late-stage changes that take place in the optic nerve resulting from axonal degeneration in the pathway between the retina and the lateral geniculate body. It is a frequent presentation, although it is not a diagnosis. Optic nerve atrophy is an important sign that may be associated with serious systemic conditions having significant bearing on overall morbidity and mortality of the patient. Optic atrophy, it can be classified as primary, where the degeneration is orderly, or secondary, where the degeneration is rapid and disorderly. It can be an ascending type, where the degeneration starts at the level of optic nerve head, or a descending type, where the injury to the retinal ganglion's axon is posterior to the optic nerve head. The aims and objectives of my study was to study clinical profile of patients with optic atrophy attending outpatient department at Dr. RPGMC Tanda. Material method, the study was conducted after taking approval from the college ethical committee. The inclusion and Exclusion criteria included patients of both genders of any age group having optic atrophy. Patients with glaucomatous optic atrophy were excluded in the study. Methodology, 30 patients, that is 60 eyes fulfilling the inclusion criteria, were included. After getting an informed consent, detailed demographic information such as name, age, gender, occupation, and address were recorded. A complete history, both ocular and systemic, was recorded. A complete ophthalmological examination along with fundus examination was done. Central macular thickness, retinal light fiber layer thickness, and fundus photo were recorded wherever possible. So moving on to the results. So out of a total of 30 patients were included, out of which 18 were males and 12 were females. Of this, the age group of 20 to 40 years of age had the maximum patients, which had 6 females and 8 males. The visual acuity assessed in 60 eyes was as follows. Maximum patient had visual acuity ranging between 3/60 to perception of light. These were 20 eyes. The second most common
Just a
group
minute.
was
Just a
having
minute.
visual
Just a
acuity
minute.
from
Just a minute.
between
There are some
6
background noises. Please mute your microphone other than the speaker. There is some background noise. You can't.
1 hour
Hello?
પછી એ લોકો પ્રોબ્લેમ રેક્ટિફાઈ કર્યો
Please
1
mute
hour બી
your
નહીં બે
microphone and the speaker.
2 કલાક
Yes, ma'am. There's some disturbance.
Oh, there are some disturbances. From where? I don't know. Okay, please continue.
Ma'am, the second most common group was having the visual acuity ranging between 6/6 to 6/18, that is 18 eyes. 4 eyes were PL negative, whereas it couldn't be assessed in other 4 eyes. Color vision of 60 eyes, 28 eyes had abnormal color vision, whereas 13 eyes had normal color vision, and in 19 eyes it couldn't be assessed. In the abnormal color vision, 21% were partially colorblind, whereas 79% were totally colorblind. In unilateral and bilateral disease, 15 people had a bilateral disease, whereas 13 had unilateral disease. Moving on to the pupillary reaction, 33 eyes had a normal pupillary reaction, whereas 13 eyes had a relative afferent pupillary defect. 4 eyes had a total afferent pupillary defect, whereas in 4 eyes the pupils were fixed and dilated, whereas 6 eyes showed sluggish pupillary reactions. Optic discs findings of 60 eyes. Partial optic atrophy was seen in 35 eyes, and complete optic atrophy was seen in 10 eyes. 13 eyes were normal with the normal disc, and in 2 eyes, the disc couldn't be assessed due to media haze. This was an 8-year-old female child with history of recurrent craniopharyngiomas with diminution of vision in both eyes. She was PL negative in right eye, whereas PL positive in left eye. This was a 48-year-old female having complaints of headache and diminution of vision in right eye with diplopia for the past 3 months. And the vision in right eye was finger counting close to face with restriction of movements. With subsequent MRI findings, she was found to have an orbital wall meningioma. Of all the etiologies, the most common was found to be traumatic optic neuropathy, which included 6 males. Raised intracranial pressure was also a common cause, with that included 2 males and 4 females. Then compressive lesions was found to be 1, intracranial space occupying lesions 3, genetic 2, antitubercular treatment induced was 1. Following post optic neuritis were 2 patients. Then toxoplasmosis 1, radiation induced 1, arthritic ischemic optic neuropathy 1, and unknown etiology 6 males. This was another patient with partial optic atrophy, also having an old healed patch of toxoplasma retinochoroiditis. And this was the subsequent RNFL scan and the central macular scan. This was the subsequent optic visual field defect of the same patient. This fundus photo shows is of a patient, 18-year-old male, with complaints of diminution of vision in both eyes for the past 11 years. It started with nyctalopia and is colorblind and was diagnosed to have Stargardt's disease. This was a 21-year-old male with short stature with diminution of vision in both eyes for the past 7 years. Visual acuity ranged from 6/36, which improved to 6/24 on pinhole. There was normal MRI and endocrinological reports. He's negative for Leber's hereditary optic neuropathy mutations. This patient was categorized into unknown cause. And this is the fundus photo of a patient, 27-year-old male with history of snake bite, followed by diminution of vision in both eyes over the period of next 3 months. The visual acuity was just hand movement close to face in both eyes. Moving on to the discussion, Vivian et al. Studied 104 patients with non-glaucomatous optic atrophy and concluded that etiology was unknown in 45.2% patients, choroidoretinal diseases 23.1%, trauma 13.5%, toxic nutritional 7.7%, and compressive lesions 4.8% being the most common among the known etiologies. V. Menon et al. Found craniopharyngioma to be the most common cause of bilateral optic atrophy in less than 20 years of age, and head injury due to road accidents and periocular trauma was the most common cause of unilateral optic atrophy in males. Vascular factors were the cause of optic atrophy after 40 years of age, highlighting the significance of thorough systemic evaluation. In our study, we found out traumatic optic neuropathy to be the most common cause of optic atrophy in men, as they are more often involved in activities causing trauma. Raised intracranial pressure was found to be the most common cause of optic atrophy in women, with idiopathic intracranial hypertension being the major contributor. A large number of male patients were found to have optic atrophy due to unknown etiology. Optic atrophy is the end result of injury to the anterior visual pathway from a myriad of disease processes. A broad knowledge of the etiology of optic atrophy is needed to make a diagnosis. Pupillary reaction, color vision, visual fields, and fundus examination are important modalities in picking up optic nerve disease. It can be an important sign of early intracranial space-occupying lesions, which have an impact on morbidity and mortality of the patients. A number of hereditary diseases go undiagnosed due to lack of testing facilities and high costing of the tests. Thank you.
Thank you, Dr. Nakul. There's a question for you.
Yes, ma'am.
Your thesis topic was clinical profile of patients with optic atrophy. So obviously you must have taken only the patients of optic atrophy.
Yes, ma'am.
So what is the explanation for those cases in which you had a visual acuity of 6/6, normal fundus findings, and pupillary reaction absolutely normal?
Ma'am, most of them were having traumatic optic neuropathy where the other eyes were normal.
So you have taken the fundus findings and the visual acuity and all these things of the other eye?
Yes, ma'am, of both the eyes of all the patients, wherever possible.
No. Actually, if your thesis was on optic atrophy, either you have compared the two eyes, or if you are mentioning the findings of the patient of the eyes with optic atrophy, only that should be mentioned. In this, you should not have mixed the findings of the two eyes together in one graph.
Yes, ma'am.
Okay. Nothing else from my side, Dr. Majumdar?
Yes. You, Dr. Nakul,
Yes, ma'am.
did you do any objective tests like for detection of optic atrophy, or just to clinically diagnose it?
Objective test, ma'am. The RNF will find retinal nerve fiber layer thickness. That's all. And
RNFL thickness.
yes, ma'am.
That means you have done OCT.
Yes, ma'am. And central macular thickness as well.
Central macular thickness. So did you go for VP? I mean, how did you diagnose those cases of optic atrophy?
Ma'am,
How did you
clinically,
categorize those cases? Because you have taken color vision also. So
yes.
if some cases were no PM, so how
Yes,
did
ma'am.
you assess color vision in those eyes?
Ma'am, I have mentioned that it could not be assessed in those eyes.
Okay, then so you assess color vision on the other eye.
Yes, ma'am.
So what is the benefit of this? What is the significance?
Ma'am, the benefit is if there's an early, like it can be, the patient can be having some intracranial space occupying lesion that could be picked up early so that the patient can be operated at an early time. Like the lady, she had complaints of diplopia with optic atrophy already set in for the past 3 months with proptosis.
Okay, so you categorize traumatic optic neuropathy, optic neuritis, right?
Yes,
And
ma'am.
papilledema. I mean, the cases with intracranial lesion.
Yes, ma'am.
So you must have done some investigations.
Yes, ma'am. The MRI findings have been recorded, whereas in
And
patients with
any blood examinations
no, ma'am, nothing as such. So
and systemic examination, nothing.
systemic, ma'am, just the routine blood pressure and
Blood sugar.
yes.
Okay. Okay.
Okay, Dr. Cool.
Yes, ma'am.
Anything else, Dr. Swati?
No, I have finished.
Okay. Who is the next speaker we have? Dr. Kamlesh?
Yes, ma'am.
You are the
Ma'am.
next speaker? No.
Yeah.
Okay.
I'll share my screen, ma'am.
Yeah.
So is it visible, ma'am?
Yes, it is visible.
Just a second. So I'm presenting good evening, everyone. I'm presenting the thesis abstract. My topic of the thesis is a study of visual outcome and complications of scleral fixated intraocular lens. Aphakia is the most important complication of cataract surgery nowadays. One of the major complications of modern cataract extraction surgery is posterior capsular tear. When the posterior capsular tear is large or the anterior capsular rim is unstable, the SFIL, that is scleral fixated intraocular lens, can be implanted. Though SFILs have good visual outcome and has been proved to be a good alternative to secondary IOL implantations procedures, it has some disadvantages of its own. This study is conducted in view of studying the visual outcome and various intraoperative and postoperative complications associated with SFIL. So the aim of the study is to study visual outcome and complications of scleral fixated intraocular lens. The objectives are to find out indications for scleral fixated intraocular lens, to measure visual acuity in patients with scleral fixated intraocular lens postoperatively, and to note complications of scleral fixated intraocular lens intraoperatively and postoperatively. This is the hospital-based study done at Ophthalmology Department of Bharati Vidyapeeth Medical College and Hospital, Sangli in Maharashtra. The study included 36 eyes of 36 aphakic patients presenting to Ophthalmology Department between January 2020 to June 21 after obtaining institutional ethical committee clearance. So the inclusion criteria is the complicated cataract cases with capsular bag rupture with surgical aphakia, cases with eye trauma with aphakia with total absence of capsular bag, and cases with ectopia lentis. The patients who had pre-existing corneal opacities or corneal pathologies, vitreous, choroidal or retinal pathologies were excluded from the criteria, and patients who did not complete 3-month follow-up were also excluded. So after attaining the informed and written consent separately from the patient, so detailed history and preoperative ocular examination was done, which included preoperative visual acuity assessment, intraocular pressure, anterior segment evaluation, fundus evaluation, and alpha hour calculation. Systemic examination and routine investigations were also done, and post-operative examination, pre-operative depression included eyelash cutting and xylotoxin sensitivity testing, mydriasis, akinesia, and anesthesia with peribulbar block, lowering of IOP, cleaning of skin and conjunctiva, and draping of the surgical field. Ab interno technique was performed for the suture passage in this study, and Levis technique was used to fixate the IOL. Intraoperative complications, if any, were noted, and post-operative management and evaluation was done on post-operative day 1, day 7, 1 month, 3 months, and visual acuity and complications were noted. So, coming to the results and discussion part, 36 size of the 36 patients having unilateral aphakia were included in this study. The mean age of the patient was 59.13 years. Maximum patients were in the age group of 61 to 70 years. Males and females were almost equally affected, with male-female ratio being 0.9 to 1. In this study, right eye was more involved compared to the left eye. Surgical aphakia was the most common indication for SFI in this study. A spontaneous dislocation of lens, that is ectopia lentis, was second most common indication of SFI, followed by the traumatic aphakia with the history of blunt trauma to the aphakic eye. Preoperative examination showed BCVA, that is best corrected visual acuity of 618 or better on Snellen's visual acuity chart in 18 patients, whereas 14 patients had BCVA of 660 or less. All 36 patients were coming to the post-operative examination. Post-operatively, first the best corrected visual acuity was examined. All 36 patients were examined on post-operative day 1, and visual acuity was measured on Snellen's chart. 20 patients showed best corrected visual acuity of 618 or better on post-operative day 1, whereas 11 patients had BCVA of 660 or worse. This visual acuity was largely affected by the post-operative complications, and as the complications resolved over the next 3 months, final visual acuity also improved. BCVA improved to 618 or better in 30 patients on post-operative day 7. Only one patient had BCVA of 660 on Snellen's chart. This improvement was maintained at 1 month and 3 month follow-up, and at 3 months, final BCVA of 618 or better was achieved in all 36 patients. Out of 36 patients, vitreous. Now coming to the complications, out of 36 patients, vitreous hemorrhage was observed in 2 patients intraoperatively. These complications were managed conservatively with topical medications, and vitreous hemorrhage resolved in both patients in 1 month. 34 patients did not have any intraoperative complications. Most common post-operative complication observed was corneal edema, seen in all 36 patients on day 1. This was followed by anterior chamber reaction, seen in 25 patients. These complications were also managed conservatively with topical steroids, and complete resolution was seen at 1 month follow-up. Hypema was seen in 8 patients on post-operative day 1. These patients were advised to maintain proper position. It gradually resolved over next 1 month, and no patient had hypema at 1 month follow-up. Another common complication, post-operative complication seen in our study was hypertony, seen in 15 patients. These patients were started on topical anti-glaucoma medications after ruling out any systemic contraindications. As a result, IOP became normal in all 36 patients at 1 month follow-up. Vitreous hemorrhage was observed post-operative day 1 in 2 patients who had intraoperative VH. Both these patients were observed at 1 month follow-up and showed complete resolution of vitreous hemorrhage. One patient showed IOL decentration at 3 month follow-up, but this IOL was still covering 80% of the pupil in this patient. Hence, the final best corrected visual outcome in this patient was 612. None of the patients in our study had cystoid macular edema, retinal detachment, glaucoma, suture erosion, or endophthalmitis. The major limitation of this study is the mean follow-up period of the patients in this study is 3 months, and some delayed complications like suture erosion, glaucoma, retinal detachment could not be assessed in this study. We have seen mostly after 6 months. So coming to the conclusion, in this hospital-based prospective study conducted at Tertiary Care Hospital in Western Maharashtra, we studied visual outcome and complications associated with SFI. From this study, we concluded that the combined anterior vitrectomy and scleral fixated intraocular lens is effective and safe procedure to correct aphakia in eyes without adequate capsular support. It provides excellent visual outcome as well as less postoperative complications, and it avoids disadvantages associated with spectacles and contact lenses uses like akinesia, anisokinesia. Also, it is superior alternative to anterior chamber intraocular lens and iris fixated intraocular lens, and it decreases the complications like bullous, pseudophakic bullous, keratopathy, and CAB. Though postoperative though thorough postoperative examination, meticulous surgical technique, and treatment of complications following the surgery is essential to get the best possible outcome. But the longer follow-up period is required to assess the long-term postoperative complications like suture erosion, pseudophakic bullous keratopathy, glaucoma, and retinal detachment. These are my references. Thank you. Hello.
Hello. There's so much of noise, I can't ask anything.
Dr. Kamlesh?
Yes, ma'am.
Okay, what were your exclusion criteria?
Huh? Sorry, ma'am.
You included all patients, all aphakic patients.
No, ma'am. Not all was very
What are the
taken.
exclusion criteria?
Basically, the patients who had any corneal pathologies or any retinal pathologies which will affect the postoperative visual outcome, those were excluded in this study. Also, the follow-up period was taken as 3 months. So, whoever was not ready for the 3-month follow-up, those were also excluded.
Dr. Kamlesh?
Yes, ma'am.
Was this scleral fixated IOL was implanted in any patient immediately at the time of posterior capsular rupture, or it was done secondarily?
Most of the patients were secondary IOL implantation, but few cases, like 3 patients, there was the primary IOL implantation.
You have shown very good results with these lenses.
Yes, ma'am.
What does the literature tell you?
Ma'am, the literature, the comparison with the other studies like Amar et al. And the Hess et al., all those studies showed same results, ma'am. Actually, the scleral fixated intraocular lens implantation is primarily done by the posterior segment surgeon, that is vitreoretinal surgeon. So, if the preoperative examination is normal, like patient doesn't have any comorbidity, the retinal comorbidity, corneal comorbidity, then in such patients, if scleral fixated intraocular lens implantation is done, then the visual outcome is very good. So in our study, we have excluded all those patients. That is why my visual BCVA is very good. The outcome is very good.
Usually in those patients, which you have included in your study, have a vitreous prolapse also.
No, ma'am. Vitreous prolapse was not noted in any patient. Actually, vitreous hemorrhage was noted in those two of the patients intraoperatively. Preoperatively, there was no vitreous hemorrhage.
So no anterior
it was.
So before that, before implanting, was that?
Actually, anterior vitrectomy was done in all 30. Hello.
Hello, I can hear.
Yes, ma'am. All 36 patients underwent anterior vitrectomy, ma'am. That is why vitreous prolapse was not noted.
Okay, thank you.
Yes.
So, Dr. Kamlesh.
Yes, ma'am.
What about the condition of the pupils?
Sorry,
because there are some traumatic cases. So, in case of traumatic midriasis,
yes,
how
ma'am.
did you do that? What was your result?
Traumatic midriasis cases, they improved actually, ma'am. The visual acuity was also improved in such patients, ma'am. Traumatic midriasis as such was not seen in any 6 patients were there, ma'am. With 5 patients were there who had a history of trauma. So those patients, they did not present with the traumatic vitreous. Yes.
Okay, thank you, Dr. Kamlesh.
Thank you so much. Thank you.
Any other speaker? Dr.
Yes, ma'am. Myself, ma'am, I am.
Who else are left? Dr. Shagufta and Preeti?
Yes, ma'am.
Ma'am, I'm also left, Dr. Asim.
Okay. Now, Dr. Preeti, you start with your presentation.
Okay, ma'am. Yes, ma'am.
Yes, you are.
Ma'am, is it visible?
Yes, you are.
Yes, ma'am. Ma'am, shall I start now?
Yes.
Good evening to all. Myself, Dr. Keratoconus. I am a postgraduate trainee from Assam Medical College and Hospital. My topic is multiplex polymerase chain reaction for the detection of HSV1 and 2 in patients with viral keratitis. HSV is the most common infectious cause of corneal blindness in the Western countries. It is diagnosed based on the clinical presentations mainly, but can often be confused with other etiologies, leading to errors in treatment and delayed resolution. Marangon et al. In their study reported that 5% of the clinically diagnosed HSV keratitis were due to adenovirus and 2.7% were due to enterovirus rather than HSV. Rubin et al. Reported a misdiagnosis of varicella zoster virus keratitis as HSV1 keratitis in 8% of the patient. Polymerase chain reaction is a molecular-based technique. It's a rapid test to detect the DNA of an infectious agent without waiting for the culture results. The aim of the study is to evaluate the use of multiplex polymerase chain reaction in the detection of HSV1 and 2 in patients with viral keratitis. The objective is to detect the presence of HSV1 and 2 DNA in the corneal scrapings or the conjunctival swabs of the patients with clinically suspected viral keratitis. A hospital-based observational study was carried out with a sample size of 35 patients. Patients above the 15 years of age with clinically suspected viral keratitis were included, and those patients with combined bacterial or fungal infection and other corneal degenerative or immune-mediated keratitis were excluded. After the consent and all the ethical formalities, the study was carried out. A detailed history, including the onset and duration of symptoms, predisposing factor, previous episode, and use of any medication was taken. A complete ophthalmological examination was done in the slit lab. The conjunctival and corneal swabs were collected with a sterile swab stick in a sterile tube containing a trisacetate EDTA buffer. The DNA was extracted using the Kyogen DNA extraction kit, and multiplex polymerase chain reaction was performed to amplify the DNA. The amplified products were detected using a gel agarose-based electrophoresis, which were viewed in a UV trans illuminator. So here in this tube, we collected the sample, and then the sample was amplified, and after that, it was detected in the agarose gel electrophoresis system, which was viewed in the UV transluminator. The cycling conditions for PCR were as follows. Here is an image of the gel product which was detected. Coming to the results and observation. In our study, out of the 35 patients, 21 patients had epithelial keratitis, 9 patients, that is 25.7% of the patients had stromal keratitis, and 3 patients had both epithelial and stromal keratitis. 2 patients had endothelial keratitis. Coming to the results of PCR, HSV1 was positive in 14 patients, that is 40% of the patients. HSV2 was positive in none of the patients, and both HSV1 and 2 was detected in one of the patients. Rest 10 of the patients were negative. Coming to the viral type of the viral keratitis and the PCR results. Here we can see that out of the 21 epithelial keratitis patients, 13 of the patients tested positive for HSV1 and 1 of the patients tested positive for both HSV1 and 2. Out of the stromal keratitis patients, none of them were tested positive, and out of the epithelial and both stromal keratitis patients, only 1 patient tested positive for HSV1. None of the patients with endothelial keratitis tested positive. Here is the graphical representation of the results shown in the table. Coming to the discussion, epithelial keratitis was the most common type of viral keratitis in our study, which were similar to Sinha et al. And Raju et al. And 15 patients, that is 42.8% of the patients, with showed positive results for herpes simplex virus, similar to studies by Magdalene et al. And Ma et al. Positive PCR results were higher in case of epithelial keratitis. Magdalene et al. And Lee et al. Also reported that higher PCR positive rate was obtained for patients presenting with typical epithelial type of lesion. Atypical lesions showed lower detection of HSV, as they are usually detected late and the viral DNA is usually cleared by immune responses. The other causes of negative PCR results would be the use of prior antivirals before the collection of the sample, and use of topical anesthetics, as has been reported by Goldschmidt et al. In their study, or misdiagnosis of other ocular infections, as previously mentioned by Maron et al. And Rubin et al. Coming to the conclusion, PCR of conjunctival and corneal samples and viral keratitis can detect the presence of HSV DNA. This detection of HSV DNA by PCR is more in case of epithelial keratitis than for stromal or endothelial keratitis. Thus, multiplex PCR can be utilized to confirm the diagnosis in patients with clinically suspected viral keratitis. Negative PCR results can help us to consider other conditions that can present as viral keratitis, allowing for their early and appropriate management to prevent ocular morbidity. Samples for PCR should be collected before starting antiviral treatment to yield higher positive results. These are my references. Thank you.
Okay, thank you, Dr. Preeti.
Yes, thank you, ma'am.
What is if the patient has stromal and endothelial keratitis?
Yes, ma'am.
What percentage of patients, according to literature, by conjunctival and corneal scraping, that can be detected of herpes simplex virus?
Ma'am, according to literature, in different studies, different data have been found in like stromal keratitis around. Usually, stromal and endothelial keratitis, they are usually immune mediated, so results are often negative. But if they are, if they present with like combined epithelial and stromal keratitis, there is PCR positive detection rate is more.
That's why I'm asking why you have done PCR testing for the stromal and endothelial keratitis. You have not given the sample of anterior aqueous humor. Maybe in endothelium aqueous humor might show some positivity for herpes simplex virus.
Yes, ma'am. It could have shown, yes, ma'am. But in our study, it was not done.
Okay.
I have a question, Dr. Preeti.
Yes, ma'am.
How did you suspect viral ulcer, or how did you exclude other fungal or bacterial? You said, you told me that it was clinically
Yes, ma'am.
selected. no?
Ma'am,
So how-
ma'am,
so what is your criteria?
ma'am. Sorry, ma'am, I couldn't get you.
How did you suspect viral ulcer, not a fungal or a bacterial ulcer?
Ma'am, viral, ma'am, based on the clinical examination, epithelial lesions are usually they present with superficial punctate type of keratitis or like dendritic ulcers or geographic ulcer, and in stromal keratitis we will see like the stromal keratitis, there will be long-standing history of treatment which has not been improved with other antimicrobial treatment. So in such cases, we will suspect viral keratitis and also the symptoms. And
So stromal keratitis, while choosing stromal keratitis, there
Yes,
was history of long-term treatment, no?
yes, ma'am. I know it will be long, yes, ma'am. Or there will be like no improvement with other
But
antimicrobial.
your selection criteria or exclusion criteria was those who are on treatment, no? You have
Ma'am?
selected those patients before starting treatment.
Yes, ma'am. Before starting like antiviral treatment, if they have not like previous, some of the patients came with like somewhere already on antiviral treatment, and somewhere not on antiviral treatment. Somewhere either like they were taking
So
other
my
antibacterial
question
or
is,
antifungal.
did you include those patients? Did you include those patients, say a stromal keratitis? Sometimes they may mimic a bacterial
Yes,
ulcer,
ma'am.
or I mean the
Yes,
stromal
ma'am.
abscess
Yes, ma'am.
also.
Yes,
So
ma'am.
did you include these patients, or if you included, then what was your criteria? I mean, you have told that
That's like
you
we
have
have
having
done
history of long-term, I mean the previous medication.
yes,
So
ma'am.
how did
The
you
culture
include?
was if they were culture negative for like bacterial or endothelial, sorry, fungal elements.
Actually, it was you said that it was clinically you chose the patient clinically depending upon your
Yes, ma'am. Yes,
clinical observation.
clinically mainly.
Okay.
Dr. Preeti,
Yes, ma'am.
you have taken those patients also who were already on antiviral treatment. Won't this act as a confounder for your study for the PCR analysis of this herpes simplex?
Yes, ma'am. Some of the some negative results may be due to that factor also because they were already on antiviral.
You had so less patients. Ideally, you should have included more patients and excluded these type of patients. That would have
Yes,
given
ma'am.
you the better
Actually,
results.
because of the COVID pandemic, there were many few patients.
Okay. Thank you so much, Preeti.
Yes, ma'am. Thank you, ma'am.
Yes. Who is the next student presenter?
Ma'am, should I present? Mine is also.
You are Dr. Singh. Yes, you can.
Oh, yes, ma'am. I'll share my screen. Ma'am, I'm having some issue. It will disconnect for a while, ma'am, if I share. Can I join in 2 minutes, ma'am?
Okay. Maybe Dr. Shagupta can continue.
Ma'am, is my screen visible now? Hello?
Yes,
Yeah, we can see your screen.
Yes, ma'am. Good evening, everyone. I'm Dr. Aseem Kumar, PGGR from AIMS Raipur. I'm presenting my thesis abstract, Evaluation of Changes in Ocular Parameters in Patients Undergoing Hemodialysis. We know that hemodialysis is a treatment modality which uses a blood filtration mechanism in patients who are having renal failure. So hemodialysis causes fluctuations in various metabolic parameters in the body, like blood urea, blood electrolytes, blood glucose, serum albumin, which leads to a loss of body fluids and decrease in the serum osmolarity of the body. And it also alters the blood vessels and the extracellular fluids. And hemodialysis also has various complications which can be divided into systemic and ocular. The ocular parameters which are affected in a patient undergoing hemodialysis are intraocular pressure, retinal nerve fiber layer thickness, central macular thickness, ganglion cell complex thickness, and choroidal thickness. So the justification for my study. Studies published till now have shown conflicting results with regards to the effect of hemodialysis on intraocular pressure and macular thickness. And the effect of hemodialysis still remains unclear till date on what effects does this cause on the ocular parameters. And there is no standard protocol. And there is no standard protocol for regular ophthalmic evaluation in all patients undergoing hemodialysis. So in our study, we compared short-term changes in the following parameters before and after hemodialysis: the best corrected visual acuity, intraocular pressure, and retinal parameters like central macular thickness, retinal nerve fiber layer thickness, and ganglion cell complex thickness. So the retinal parameters were measured by the optical coherence tomography OCT machine, which is a non-invasive, non-contact method for the assessment of retina, and it provides an objective data about the thickness of various layers of retina. So this is an example of a macular thickness OCT scan report. This is an example of an RNFL thickness OCT scan report and of the GCC thickness OCT scan report. So various literatures till now, like Ionet et al. Have told that there has been no change in the foveal thickness. Same was confirmed by Guijiang Sun et al. That there is no change in the central macular thickness before and after hemodialysis. But some authors have told that there is a decrease in the central macular thickness, like Theodosiadis and G. Vaughan et al. Have told that there is a decrease in the thickness of the central macular thickness before and after hemodialysis, while other authors have published in their articles that the central macular thickness have increased before and after hemodialysis. Same is the condition with the intraocular pressure. Some authors have told that there is no change in the intraocular pressure before and after hemodialysis. And some have told, like Elias Chelala et al., that IOP decreases after a setting of hemodialysis. So what were the materials and methods? My study design is a prospective observational study, and it was done between January 2021 and September 2021 in Department of Ophthalmology and Nephrology in AIMS Raipur. The study variables were best corrected visual acuity, intraocular pressure, central macular thickness, retinal nerve fiber layer thickness, ganglion cell complex thickness. These are my inclusion criteria. All patients aged between 18 to 60 years planned for hemodialysis who are able to cooperate in all the ophthalmological examinations, and they have a stable intradialectic course for 4 hours. The exclusion criteria were patients with media opacity like cataract, vitreous hemorrhage, which interferes with the image quality in OCT, and patients with history of retinal detachment, macular degeneration, or any other ocular trauma. Patients with history of intraocular surgery, intraocular injection, or retinal laser therapy were also excluded from the study. And patients who became unstable during their course of hemodialysis were also excluded from the study. So how was the study done? First, the patient were assessed for their eligibility. Then the history and ophthalmic examination was done. The pupils were dilated using tropicamide and phenylephrine drops. Then the fundus examination was done using indirect ophthalmoscope. Then the OCT was done. Then the patient underwent a hemodialysis, and again after the hemodialysis session, the visual acuity, intraocular pressure, and OCT biomarkers were evaluated. So these are my results. Firstly, the gender distribution: 33% were females, 66% were males. In the age distribution, most of the patients were in the older age group. 40% were 51 to 60 years old, 20% were 41 to 50 years old, and 30% were in 18 to 30 years old. And the diagnosis of the patients were chronic kidney disease in 21 of the patient, and acute kidney injury in 9 of the patients. So these are the before and after results before and after a session of hemodialysis. That is pre-dialysis and post-dialysis. These are the values of the best corrected visual acuity, the IOP, the central macular thickness, the retinal nerve fiber layer thickness, and the ganglion cell complex thickness. So as you can see, that the IOP, CMT, and GCC have decreased after a session of hemodialysis, but there has been slight increase in the retinal nerve fiber layer thickness, and the BCV has not improved that much significantly. Here's a same graph showing the values pre and post hemodialysis. We have included the creatinine, urea also. The blue ones are the pre-dialysis, and the right side, it's post. These are the p-value which were calculated using the data. So now coming on to the discussion, hemodialysis leads to various changes in the metabolic parameters of the human body, including changes in the level of blood urea, creatinine, electrolytes like sodium, potassium, and also induces changes in the osmotic values of the blood and extracellular fluids. There can be an effect of hemodialysis on the aqueous and vitreous humor of the eyes, which can predispose to changes in various ocular parameters like visual acuity, intraocular pressure, etc. It can also lead to changes in the retinal parameters of the eye. In our study, we found that there was no significant difference in the best corrected visual acuity before and after a session of hemodialysis, but there was a significant reduction in the intraocular pressure from 15.16 plus minus 1.66 millimeter of mercury before dialysis to 14.60 plus minus 1.52 millimeter of mercury after dialysis. In the previous studies, there were contradictory results regarding the increase or decrease of intraocular pressure, but in our study, we found that the IOP reduced significantly after the session of hemodialysis. Moreover, in the previous studies, all the participants were suffering from end-stage renal disease, but we also included the patients of acute kidney injury in our study. Many studies have also shown that hemodialysis affects retinal parameters. We examined the central macular thickness, retinal nerve fiber layer thickness, and ganglion cell complex thickness before and after a single session of hemodialysis. In our study, we found that there was a decrease in the central macular thickness and ganglion cell complex thickness, and an increase in the RNFL thickness after a session of hemodialysis. However, none of these changes were statistically significant. Coming on to the conclusion, this is an interim data analysis of my thesis, as this is showing only the data of the 30 patients. It has shown a significant decrease in intraocular pressure and some changes in the retinal parameters, which are not significant at the current stage. However, a definite conclusion regarding the changes in retinal parameters will be reached once the required sample size is met. These are my references. Thank you.
Thank you, Dr. Seem.
Yes, ma'am.
You have not looked for the choroidal thickness pre and post hemodialysis?
No, ma'am. We have not looked for the choroidal thickness.
Literature must have shown there must be some changes in the choroidal thickness as compared to the retinal thickness.
Yes, ma'am. There were, in the literature, it was given that also there were contradictory results, ma'am, regarding the choroidal thickness also.
Okay. And why your thesis was completed in the duration of January to September?
No, ma'am, it was not completed. This is just an interim data analysis, ma'am.
Okay.
My sample size is 113. But for this presentation, the first 30 patients I have taken and do the data analysis for that patient, ma'am.
Does that statistical analysis of the intraocular pressure by decreasing from 15 to 14 was significant?
Yes, ma'am. The p-value was significant, ma'am, less than 0.05.
Okay. Okay, till now, so your final conclusion is there is no significant changes in the hemodynamics of the eye by the hemodialysis.
Yes, ma'am. Till now, there are changes, ma'am, in the thickness of the various layers of the retina, but those are not statistically significant, ma'am, till now. Only the intraocular pressure has been shown to statistically decrease, ma'am, after a session of hemodialysis, ma'am.
Okay.
Dr. Ashim,
Yes, ma'am.
sorry, Dr. Bog, do you have any question? You may ask.
No, you can carry on.
Okay, Dr. Ashim,
Yes.
was there any difference between the findings of hemodialysis following diabetic kidney disorder or hypertensive kidney disorder?
No, ma'am. Even on those patients, the decrease, there was no correlation, ma'am. I still have to do a linear correlation of the various changes, ma'am. But till now, what we have seen, there was nothing correlating with the changes in patients who were diabetic and who were hypertensive regarding to the changes in the retinal layer thickness pre and post hemodialysis, ma'am.
It was a single session hemodialysis, no?
Yes, ma'am. It was a single session hemodialysis.
After first hour or second hour of hemodialysis, you have taken all those findings?
Sorry, ma'am.
After first or second hour of hemodialysis, you have recorded all those findings?
Ma'am, before the patient was shifted to the hemodialysis unit, ma'am, within 1 hour before shifting the patient, and after the hemodialysis is complete, then within the next 1 to 2 hours, ma'am.
How did you measure intraocular pressure?
Ma'am, by Goldman applanation tonometer, ma'am.
Applanation tonometer.
Yes, ma'am.
And you also compensated the corneal thickness for each?
No, ma'am, I have not done corneal CCT, ma'am, for the patients.
Oh, you measured central corneal thickness individually, but you did not correlate IOP with CCT. That means it was not CCT corrected IOP, no?
No, ma'am, the IOP was not CCT corrected, ma'am.
Okay, that's all.
Okay.
Okay, thank you, Dr. Singh.
Okay, thank you, ma'am.
Next speaker. Who is the next speaker, Dr. Anybody left? Anybody left for the presentation?